So, my name is Dr. Kirsten Rolling, and I'm a public health dentist in Phoenix, Arizona. I have been in the dental profession now for about 43 years, which is unbelievable. I started in dentistry as a registered dental assistant prior to wearing PPE, prior to the AIDS epidemic. And things changed quite rapidly early on in my career. I'll be sharing that with you today. I went on to go to dental school at the University of California, San Francisco, and did some research while I was there, and then went on into both private practice and public health practice, and eventually landed in public health practice full time. I was the chief for the Office of Oral Health for Maricopa County's Public Health Department. It's the third largest public health department in the US. And I was charged with overseeing multiple oral health programs, pediatric as well as older adults. And from time to time, I was asked to accompany our dental board to inspect dental practices. Prior to that, I was a consultant that inspected dental practices. So I will be sharing some of those experiences with you today. You'll see that I have a very no-nonsense approach to things, and I believe in science. So I'm going to be talking to you about evidence-based solutions today. And if you have any questions, please type them into the chat area. If you happen to be watching this at a later date, later than March 15th, this is a recording. For you to receive CE credit, you will scroll below the video player and go to the instructions section, and number 3 is the quiz. In your handout, you'll see a link, those of you that are attending live, to the quiz again as well. We recommend that you log in right now to that quiz and complete it while we go along. I do want to thank IQAir for sponsoring this course. They have sponsored this course for almost 3 years. And again, I will be joined by Glory Dolphin-Hamas, the CEO of IQAir, after the first part of this presentation, the first half. And she is a globally recognized air quality management professional, especially when it comes to healthcare. So if you have questions, and I think you will, please stay on for that segment and ask away, because she is just a great resource. So we want to thank all of you for being here today as well. There are the learning objectives. I'm not going to go through them one by one, but I am going to put a survey up on the screen for those of you that are attending live today. And I ask that you answer the survey. So let me go ahead and post that for you. All right, so on the screen, you will see 1, 2, 3, 4 questions. You might need to scroll down. And we'll take a minute to get that answered. Again, if anybody has any questions today or needs a little help, let us know by posting in the chat area. Your CE certificate is sent to you by email. This is a very large class today, so be sure that you get your questions answered. If there's a question that I don't have an answer for, and occasionally that happens, I'll research it for you and get back to you. Okay, just a few more seconds on the survey. Right now we're at 50%, so we do need you to hop on here The questions are anonymous answers. So there are no stupid answers here today. They might be the wrong answer, but they're not stupid answers. You can do the quiz while we present the course today. Yeah, so that you all will be done. The passcode is presented at the end. First question, our practice currently uses surface disinfectants that are sporicidal. True, false, I'm not sure. Second question, our office performs autoclave biological monitoring either daily, weekly, or monthly. Next question, hands should be washed after glove removal. True or false? And the last question, the person responsible for the oversight of infection control in our dental practice is dental assistant, dental hygienist, front office, no one in particular. I am not sure. I did not include the dentist on here. I've been asked to do that, but I haven't done it because I'm looking for the person that is responsible for the actual oversight. You can take the quiz multiple times. Okay, I'm going to go ahead and wrap up this survey here. All right, so the first question was answered the following. Our practice currently uses surface disinfectants that are sporicidal. About 52% of you that answered the survey today answered true. 3% that answered the survey answered false. And about 13% of you that answered the survey not sure. So we didn't have a full 100% that answered the survey today, but about 70%. The majority of you are using microfiber towels in a tub, right? Probably Cavicide. Those are quaternary ammonium compounds. We know about probably 95% of dental practices use quaternary ammonium compounds, and you're going to see a document that I've included in your course folder about quaternary ammonium compounds called QACs or quats. Highly toxic, by the way. And they are not sporicidal. When I'm talking about sporicidal, I'm not referring to the tuberculocidal claim. I'm referring to the actual ability to kill bacterial spores like Clostridium difficile, which we need to be doing in dental practices. But we don't know about that. So I'm here to talk to you about that today. So if you're using the quats, they're excellent at what they're supposed to do if they're used correctly. They just don't kill everything that we need to kill in dental practices. Our office performs autoclave biological monitoring. We have 13% of you that have answered daily, 45% that have answered weekly, and 9% monthly. So the CDC, which this course aligns with today, recommends either weekly or daily. Now, in some cases, if you're processing quite a few instruments, although the CDC doesn't say how much that is exactly, you may need to actually monitor weekly, right? And hands should be washed after glove removal, true or false. 64% of you that answered the survey answered true, and 3% of you that answered the survey answered false. We should wash our hands immediately after we remove our gloves, before we touch anything, check our phone, go to the keyboard, and then wash them again, or hand hygiene, before we put our gloves back on. All right, the last question here. The person responsible for the oversight of infection control in our dental practice is, we have 37% have answered the dental assistant, 9% the dental hygienist, 2% the front office, 12% no one in particular, and 6% I am not sure. So these answers are always all over the map, but for the most part, it's the dental assistant or the dental hygienist. So I was a registered dental assistant again before we had to use PPE, before we were required to autoclave our hand pieces. We didn't wear gloves. We didn't wear masks, so my bare hands went into bloody mouths. And then AIDS came along and changed quite a bit of our protocols. All right, any questions about the survey? Okay, on the screen briefly is a course offered by Dr. Palmier, who is the co-author of the American Dental Association's guidelines for antibiotic prophylaxis and odontogenic and therapeutic clinical applications. We are hosting this for a couple of reasons. The ADA no longer recommends clindamycin for prophylaxis for your penallergic patients or initial infection. And we know that many dental practices out there did not get the message. So we do want to let you know that this course is available. And the second reason why I have this course is that many of you know I developed Clostridium difficile infection after a dental procedure 2 years ago that followed a course of antibiotics. And it almost killed me. So I learned quite a bit, and I learned perhaps what many of you don't know either, that I didn't know. So if you have the opportunity to take this course, it's a 4-hour training. I highly recommend it. Dr. Palmier is a great resource for you all. And on the 28th, it's live. And in the afternoon, he's also offering a 2-hour course on opioids, substance abuse as well. So there is the link. And it's also available to you as training for on demand. All right. So shameless plug there, but I'm trying to do my part to make sure that all of you have the resources you need to effectively treat your patients and not expose yourself to liability as well. All right. Again, if you are looking for the quiz instructions in the handouts, you can tap on that red banner at the top of the screen. Let's talk about why infection control is important in dentistry. I think many of us know this, but both patients and dental healthcare personnel are exposed to pathogens all day long. If you go to a medical office right now, the physician, if you get to see one, or probably the nurse practitioner, when they walk through the door, they're going to sit about 15 feet away from you. And they're going to ask you a few questions. They're going to type answers into a laptop, probably, order some labs, order prescription or two, and that is it, unless it's some procedural program that you're there for. In dentistry, we are very procedural, right? Every interaction that we have with our patient just about requires a tray setup and sterile instruments. And we're exposed to aerosol all day long, and we're exposed to contaminated surfaces. So it's a much different way to practice, and our occupational exposure is much different. Contact with blood, oral, and respiratory secretions, aerosol, contaminated equipment occurs throughout the day. We need proper procedures to prevent transmission of infections among our patients and our team. In the US, an estimated 9 million persons work in healthcare professions. There's the breakdown for you. Again, dental assistants come out at the top. And these are just a few of the pathogens that we are exposed to every day. Cytomegalovirus, hepatitis B, hepatitis C, herpes simplex virus types 1 and 2, HIV, Mycobacterium tuberculosis, Staphylococci, Streptococci, SARS-CoV-2, SARS-CoV-1, other viruses and bacteria that colonize or infect the oral cavity and the respiratory tract. But we also have to be concerned about pathogens that infect the gastrointestinal tract and transmitted initially by the oral fecal route, but most commonly through cross-contamination in the healthcare environment. One of those that we need to be concerned about right now, which many of you may have experienced, is norovirus, right? Norovirus is a gut virus. We call it, quote, the stomach bug or the cruise ship virus. And that can go through a dental practice in a matter of days. It's very, very contagious. What do you need to do in these cases? Number one, protect the mucosa using PPE and hand hygiene, frequent hand hygiene. The first influenza pandemic of the 21st century was swine flu. It was April 2009, and it was a genetic composition of swine, avian, and human influenza, and it emerged in the US and Mexico, spread to person. Now, I actually was working in a public health department and became ill with swine flu very early on because I was treating children, and it was right after one of the school breaks. They came back from spring break, and many of them had been on vacation and so forth, and I became very ill. I was off work for about 6 weeks. I was quarantined by the public health department, not in Maricopa County, different one. For the first 3 weeks, I was given Tamiflu. This was before Instacart, so I had no food in the house. I had to have friends drop off meals to me. They had to stay 100 feet away from my door. So let's look at modes of transmission here. And again, if you have any questions, I'll be checking in time to time. If we get a little ahead of ourselves, I will let you know to hold that question and we'll revisit it. So an OSHA coordinator is different than the oversight of your infection control program. An OSHA coordinator is not just to do with bloodborne pathogens, but OSHA is to protect employees, not the patient. Right? So that has to do with occupational exposure. But yes. Now, is it a requirement in every state? No. Okay, modes of transmission here. We can have direct contact with blood or body fluids, indirect contact with a contaminated instrument or surface, contact with the mucosa, of the mucosa with droplets or spatter, an inhalation of aerosol that can remain suspended for long periods of time. And you'll hear Glory talk about ultrafine particles today. And your aerosol that you are exposed to, about 80 to 90% are ultrafine particles, which can embed very deeply in the respiratory tract and beyond. They are so small in diameter, they can actually enter your bloodstream like an oxygen molecule and translocate to any location in the body, any organ or tissue. I'll talk about that in a little bit more detail. All right, so the chain of infection, let's take a look at this graph here. We need to disrupt one or more of these links in the chain of infection. And that's why we're all here today. We're going to learn how to do that. Each link has a role to play, and there are different protocols that we can use to disrupt that particular link, but we don't want to maintain the chain of infection, right? We want to disrupt it. So it starts with a pathogen, bacteria, virus, fungi, or parasite, which requires a reservoir. It could be humans, animals, soil, food, and water. A portal of exit. So how does that pathogen escape that reservoir and find a new one? It can be through coughing, sneezing, bodily secretions, feces. A mode of transmission. Notice the hands on that link. Hands are the number one mode of transmission. Whether or not you're wearing gloves, that is why it's so important that you perform effective hand hygiene multiple times throughout your day. Mode of transmission can be through direct contact, indirect contact, or vectors. We won't get into vectors. Those are insects or rodents. Portal of entry here, the mucosa, the mouth, nose, eyes could also be cuts in the skin. And then we need a susceptible host. We need someone who is not immune to the disease or infection that is caused by this pathogen. Now, what would that possibly be? Viruses, for instance, influenza, RSV is a horrible, horrible viral infection, and it can kill older adults. So who are these susceptible hosts? The immunocompromised, anyone that's on a medication to intentionally suppress their immune system, or someone that has a condition or disease that suppresses their immune system and they're immunocompromised. Infants, because their immune system is not mature yet. And then older adults, those over the age of 65, have greater susceptibility to infection and severe illness, hospitalization, and death. So again, we want to prevent disease transmission by interfering with one or more of the links in the chain of infection. So that reservoir is the habitat that the pathogen normally lives, grows, and multiplies. It can be humans, animals, and the environment. Human reservoirs, many common infectious diseases have human reservoirs, as we know. And these are diseases that are transmitted from persons to persons. So they can be the sexually transmitted diseases, measles, which we're hearing a lot about in the news right now, mumps, streptococcal infection, and many of the respiratory pathogens. And for an example, many of you who are probably not as old as I am, were not vaccinated for smallpox. I was, because at that time, we had to be. Smallpox was still infecting and killing many children around the globe. So, and it was a very disfiguring disease. So we were vaccinated for the first time. And that was the first vaccine campaign. And we eradicated smallpox from the face of the earth. Those of you now do not have to be vaccinated for smallpox because it doesn't exist anymore. All right, human reservoirs may or may not show the effects of illness. Those are carriers. We have to be worried about carriers because carriers walk into our dental practice frequently. We don't know who they are, and they may not know who they are. If you cannot hear or see, you might have to go to a different device. Okay, so human reservoirs may or may not show the effects of illness. There are different types of carriers out there, and a carrier is a person, again, who may have an asymptomatic infection. They are unaware that they are infected, and they are capable of transmitting that pathogen to others. I'm going to warn you right now, I'm in Pennsylvania right now, and there's a really dastardly looking thunderstorm going through here. We have backup, so don't worry, but you may hear it. And if I lose connection, we have backup here to reconnect. So, all right, types of human carriers: asymptomatic or passive or healthy carriers. They've never experienced symptoms. They're walking amongst you, they're sitting in your dental chair, they're talking to you, and they may not even know that they're infected, but they're capable of transmitting that infection to you. Incubatory carriers, these are folks that are ill. They don't know it yet. So it's the incubation period before they have clinical signs of illness. So again, they can be sitting in your dental chair, talking to you, they feel great, and the next day they have symptoms or a few days later. SARS-CoV-2 is one of those viruses that we have to be concerned about, incubatory carriers, right? So many of you may have had and may continue to have these patients sitting in your chair, and they are infectious, but they don't know that they're ill yet. Some of our patients with SARS-CoV-2 never became ill. They were infected, they were capable of transmitting the infection to others, but had never had clinical signs of illness. Convalescent carriers, those are folks that have recovered from their illness, but they're still capable of transmitting that infection to others. So I might be someone like in that category, because once you've had Clostridium difficile, there's a probability you could shed spores for a lifetime. And those spores can be on clothing, on shoes, and so forth. Chronic carriers are those that continue to harbor the pathogen, like hepatitis B or Salmonella typhi, which was the causative agent for typhoid fever, for months or even years after their initial infection. And then you can have a combination of above. You can have convalescent and chronic carrier. And famous carrier was Mary Malone, who was known as Typhoid Mary. She was an asymptomatic chronic carrier of Salmonella typhi. She was a cook in New York City and infected dozens of people with typhoid. So at that time, the public health department, social isolation, she was put on an island and she lived there for 23 years because at the time there was no cure. So instead of wiping out humanity, they isolated her from the rest of the world, which is sad, but that was the only thing that could be done. There's a famous story, a famous book on Molokai, the island of Molokai, and there's an area of Molokai Peninsula that is now a national park, but it was where patients or citizens with leprosy were taken in Hawaii to this particular area of the island, and they were isolated from the rest of the world. And they were put on a ship, and the ship captain would take them to the island of Molokai and drop them off in the ocean where they had to swim to shore themselves and pretty much fend for themselves. So it's an interesting story about how this played out. Now, Hansen's disease, of course, has a cure. And these patients, they still have former patients that live on the island. At least they did at the time that I toured it. All right, animal reservoirs. We're not going to talk a whole lot today, but of course, we are familiar with some diseases that have animal reservoirs. Bats, birds. Mpox is thought that latest outbreak was thought to be from the importation of prairie dogs, for instance, SARS-CoV-2 bats, West Nile birds, and so forth. All right, environmental reservoirs. We won't go into deep detail, but we have environments in our dental practices that we need to be worried about. The water is an environment. Our water has to be treated. It has to be tested. It has to be safe for our patients. When it's not, it can cause real issues, not for just our patients, but for ourselves, because it creates aerosol also. And Legionnaire's disease is one of those that we have to be worried about in our aerosol. The other is non-tuberculous mycobacterium and Pseudomonas aeruginosa. All right, other examples here, Clostridium difficile in the environment are found everywhere, but they're found in much greater numbers, the spores in healthcare practices. Valley fever is an example of the Southwest infection that can occur from a virus, fungal, Coccidioides immitis, and it's in bird droppings, and it ends up that it can stay surviving in dirt, in dust for years and years and years. So when we have some sort of dust storm that kicks up in Arizona, we have increased numbers of folks with valley fever. Okay, portal of exit, how the pathogen leaves its host. So the portal of exit usually corresponds to the site where the pathogen is localized. Again, it can be through coughing, sneezing, feces, etc. So right now we're worried about a few respiratory infections. Of course, COVID-19, RSV is another one. Influenza A, which has been a really tough deal for a lot of people this year. Croup is making its way around. So covering the airway is important if you don't want to become ill, and making sure that you're cleaning the air and monitoring the air quality. And we'll talk about how you can monitor your air quality in your dental practice. And then modes of transmission, again, can be through direct contact with the patient, through droplet spread as well, or indirect transmission through aerosol, vehicle-borne, so contaminated instruments, contaminated surfaces. And direct contact, again, for our purposes in dental practices, it would be patient contact or contact with the patient's body fluids, and droplet spread. Droplet spread, we'll talk about. Droplet spread refers to aerosols. Aerosols come in different sizes, and that's how we classify them. So droplets, droplet nuclei, spatter, and ultrafine particles, breaking it down. The ultrafine particles are the smallest in diameter. They're light in mass. We said they can pass through the respiratory tract, enter the bloodstream like an oxygen molecule, circulate and be translocated anywhere. Droplets and droplet nuclei would be the second category, the second smallest category. And they are so light in mass as well. They usually will get disrupted by the respiratory system, at least, but very deeply embed in the respiratory system. And then spatter. So spatter are the large particles that will behave like ballistics in your operatory. They'll bounce around. They're short range, relatively short range. And eventually gravity will bring them down to earth. They'll run out of energy. And we'll talk about that in more detail. All right, indirect transmission again can be through aerosol, inanimate objects. In our case, it would be contaminated instruments, contaminated surfaces. So question here, cold sores. Some doctors will say reschedule, others say proceed. I'm always inclined to reschedule for patient safety and my own, including others in the office, due to aerosols and risk. Thoughts? Well, if the cold sore is still in the bolus phase, the standard of care is that we don't see the patient, right? If your patient comes in with a cold sore that is in the bolus phase, the blister phase, or the blister has broke, that is just chock full of viral particles, right? So I rescheduled them, and it's uncomfortable for the patient. So although it's not a respiratory infection, it's more of a contact infection. Overall, it's just a better idea, it's just better for everybody involved that you don't treat the patients. Now, if you look at the standard of care, they say if it's scabbed over, they're probably okay. But in my case, I prefer not to see them. Is there not a straw system for the water? Then we need to be using the blue tabs. It depends on what your manufacturer tells you to use, but you still need to test your water. Great, Tasha. I'm glad to help. Thanks for the feedback. Okay. Again, we spoke about droplet nuclei. Droplet nuclei are small in diameter as well. They're evaporated droplets, so they're highly condensed, highly pathogenic. And because they're so small in diameter and so light in mass, they hang around the operatories. They don't just stay in the operatory. They'll head on down the hall, maybe to your reception area, maybe to your business office. Measles happens to be one of these infections that you can walk into a room where a child with full-blown measles had been. And that virus is respiratory as well. And so the patient inhales that virus and they develop measles. How many of you in here, and this is anonymous, have had measles? You can type yes or no in the private area. I won't share it. No. One yes. So we've got 2 yeses, 3 yeses, 4 yeses, 5 yeses. Majority, we have about 80 no's. When I was a baby in 1961. Okay, so I had the measles. I had every measles known to man. Yes, but I'm old. Yep, I'm there with you. So my mother wrote down our vaccination schedule, vaccination records, and it actually wasn't a vaccine record because at the time there was no measles vaccine. And there were 5 of us, 5 children. I was the oldest, so she'd start with me, and then you could see, a week later, my one brother had it, and the next brother. Same thing went on with German measles, rubeola, the whole deal. 2 brothers in the hospital with measles encephalitis. Really, when I looked at this, she didn't have a life at all. Mumps, chicken pox, the whole deal. one sister that's been permanently um, affected by measles, she lost her hearing. She's not able to hear, so from encephalitis. So it's really important to protect yourself. As an RDH, how can we refuse to see a patient that has a sore when the doctor wants the production? Well, that's a good question. I wish I had the easy answer for you, but I don't. The only way to convince them is if that is their mindset, is not work for them. Yep. I was vaccinated for measles, but was made to infect my brother with chickenpox. He had it worse than me. Okay. So yes, measles highly contagious, and we do have some outbreaks across the U.S. So just do everything that you're supposed to do, and you should be okay. Cover your airways, wash your hands, and so forth. All right, indirect transmission through vehicles, and these would be what in our dental practice? Contaminated instruments, surfaces that are contaminated with patient material, pathogens, and so forth, your flooring, your equipment, and so forth. And then vectors, which we won't go into today. And then the portal of entry is a way for that pathogen to enter a susceptible host. And we're going to talk about how we protect those portals of entry today. And then let's talk briefly about the host. Thank you all for sharing that information. Right. Stand up for yourself and say no. It is, but it is, as you can agree, Heather, it's a little bit more complex than that. And there is a push for production. And I was in private practice, but I didn't make anybody see someone with a herpetic lesion. Now, I will tell you, when I had C. difficile, I got a call. I was in the hospital and I called the dental practice to let them know. And I got a call back from the front office manager that said, "Are you able to keep your cleaning appointment on Friday?" And I'm like, "Are you kidding me? I'm in the hospital with C. difficile. Well, are you going to be discharged in time?" I said, "I can't come to your office for a cleaning appointment with an active C. diff infection." And that was the push to keep their hygiene schedule filled. She said, "Well, doctor doesn't need to give you any more antibiotics." And I said, "Yeah, you're darn straight about that. I'm not taking any more antibiotics, but I won't be there for your cleaning." So again, there is that concern of production. Wow. Carolyn had measles before age 1 and tetracycline was prescribed to her, and she ended up with tetracycline staining. And they may have given you tetracycline because they were concerned about meningitis too, Carolyn. That was the treatment for meningitis. All right. So host. Your host susceptibility is really important. This is the final link in the chain of infection. The susceptibility of a host can depend on genetic factors. It can depend on their current state of health, their mental health as well, their specific immunity, non-specific immunity that affects one's ability to resist infection or to limit its pathogenicity. So an individual's genetic makeup may increase or decrease their susceptibility. Specific immunity refers to what? Protective antibodies that were directed against a specific agent. That could have occurred if you were maybe infected in the past. If you were vaccinated, you may have the ability to have toxoids so that you can fight off infection in the future. I had a toxoid called Zenplava when I had C. diff for toxin B to try to eliminate the recurrent infections. Didn't work, but it's available. Non-specific factors that defend us against infection. The skin is a barrier. The mucous membranes are a barrier. Gastric acidity, gastric acid in your stomach Hydrochloric acid is there for a reason. It sterilizes the food we eat. Oftentimes, our food is not sterile, right? It also protects us from pathogens, cilia in the respiratory tract, the cough reflex, and then the nonspecific immune response. And I want you to listen closely to this because nonspecific immune response refers to really our gut microbiome. And when we prescribe antibiotics, we disrupt the gut microbiome. We used to call it the gut flora. Antibiotics, just a single dose, we can do that to our patient. And when we invite them back into our practice for a procedure, let's say a root canal, and we've prescribed an antibiotic, we've disrupted their ability to fight off pathogens in your dental practice. And one of those is Clostridium difficile. And Clostridium difficile contaminates all healthcare practices, including dental practices. We're not immune. So that is how C. difficile is transmitted. And the patient can become infected up to 3 months after you've prescribed an antibiotic. And it's any antibiotic now, any dose, any duration. So that is your non-specific immune response. So it's important that the patient needs that antibiotic and that we understand what the repercussions can be and that the patient is fully consented. And it's important that we use disinfectants that kill these C. difficile spores in our practice. And we're going to see on EPA list K, some of those. They're usually in the bleach family, hypochlorite family. We recommend hypochlorous acid, but it has to be a specific concentration and a specific pH. You can't leave here today and go to Amazon and buy something that, quote, says hospital grade. It does not mean that it's sufficient concentration to kill C. diff spores. So it would be found on EPA list K, and then it kills everything. SARS-CoV-2, MRSA, HIV, all of it. Malnutrition is another. If you have a patient that has had ongoing xerostomia and multiple root tips and you're doing a full mouth extraction, that patient may be more susceptible to infection and slower healing, right? They just don't have the constitutional factors either. Okay, so we have to disrupt the chain of infection to prevent disease transmission, and we have interventions to do that. We use PPE to cover our eyes, nose, and mouth. We control or eliminate the agent at the source of the transmission. We may use disinfectants for that, administrative controls, infection control, antimicrobials. We may need to increase the host defense through adequate nutrition, probiotics, which are considered controversial because they're supplements. The American Dental Association does not recommend that we recommend probiotics to prevent C. diff infection, for instance, vaccination, etc. Okay, so an infected host may be treated with antibiotics. In dental practices, we use disinfectants on our clinical surfaces. Intervention here, we want to interrupt direct transmission. So sometimes we have to isolate people that are ill or counsel persons to avoid specific types of contact. We may have that patient with the herpetic lesion not be seen that day, right? And really that gets down to administrative controls, whatever your protocol is for administrative controls. And those may change from practice to practice, right? But your administrative controls is not not letting that person in the front door to begin with, or not taking them to the back where they could potentially infect others. So administrative controls, early days in the pandemic, you were doing what? Taking temperatures. They were filling out their health history forms before they got there. They were sitting out in their car. They were texting when you got there. Those were all protocols designed to keep problems from walking through the front door to begin with. All right, vehicle-borne transmission, we do what? We sterilize our instruments. We disinfect our surfaces. To prevent the fecal to oral transmission, promote effective hand washing. Airborne diseases, we modify the ventilation, we monitor the air quality, we filter, we treat the air, we make sure we have enough ventilation, enough fresh air coming through as well to dilute the aerosols in your practice. And then vector-borne transmission. That is not something we're going to go into detail, but public health would control the vector population. They're going to spray for mosquitoes, for instance. The American Dental Association does not recommend probiotics while taking antibiotics because they cite a study from Infectious Diseases Society of America stating that the science is not there. I teach a course on probiotics, and I took probiotics for years prior to getting Clostridium difficile. And that's anecdotal, but probiotics are supplements. They're like vitamins. So there is not one probiotic out there that has sought FDA approval because they don't need to. It's a multi-billion-dollar industry, and they can sell their probiotics just fine whether or not they work, right? So if you look at a probiotic bottle or marketing, they will never state a claim. They will cite another study. You know, that, for instance, Lactobacillus rhamnosus GG has been shown in studies to help reduce the symptoms of Clostridium difficile, which it has. And Culturelle has a product that is Lactobacillus rhamnosus GG, or Saccharomyces boulardii, which is a yeast that is also used to treat C. difficile. They will never say on their bottle, our probiotic is going to cure you, because they can't. They're not FDA approved. So the American Dental Association stand is the way we prevent C. difficile is to prescribe correctly, to reduce the numbers. You can never prevent it 100%. Even when you're prescribing properly, a patient can still get C. difficile, right? But you've got to address the contamination in your environment as well. So make sure if the patient takes your antibiotic that they need it. If you are recommending probiotics, many hospitals use probiotics, many medical centers. Gastroenterologists are a bit divided. Some think they should be administered, and others believe it's just a waste of money. So in my case, I already took probiotics. I continued to take them throughout the infection, which was about 6 months. And then I had a fecal transplant, which is nature's probiotic, which cured me. At that point, I was told not to take probiotics anymore because it could disrupt what was already working. So I don't take probiotics anymore. Okay, so PPE is used to protect us. Eyes, nose, and mouth. Eyes, nose, mucosa, the mouth. Also to protect the patient from us. Vaccinations, again, promote specific antibodies. Previous CDC recommendations regarding infection control for dentistry focus primarily on the risk of transmission of bloodborne pathogens. And we used universal precautions to reduce that risk. So we're going into the next portion of this program. Any questions before we do? What do you do when a lot of offices don't have windows or ventilation offices? Not a lot of them use air filters. Stay on and we'll ask Glory that question. So yes, some folks will recommend yogurt. I used to tell my patients to eat yogurt when I gave them antibiotics. If you are recommending probiotics, they should be used 4 hours apart from the time they dose the antibiotic. So they should wait at least 4 hours. At the hospital, antibiotics are always complemented with probiotics. It's protocol, right? If you look at the studies, and there's, as I said, there are some excellent probiotics out there, but when you look at the studies, they're all studies that were performed by the manufacturer. So we don't have the science to show that they work. But I would still recommend to my patient to use them, right? We just don't have the science, and the American Dental Association doesn't recommend them to prevent C. difficile infection. right? The way to prevent C. difficile infection, number one, is to make sure the patient needs the antibiotic. And number two, make sure you're disinfecting your practices, because if you're inviting them back into your practice and it's contaminated, you could be subjecting them to disease. Now, that doesn't mean that you're going to be able to protect them for everywhere else they travel while they're taking the antibiotic. And that goes for employees in dental practices. We have somebody in a hospital here. If you are an employee of a hospital and you ever have to take an antibiotic, let's say it's a UTI or sinus infection or something, you are at greater risk for C. difficile as an occupational exposure. And in some hospitals, the employees are informed through HR. You're at risk. We recommend that you wash your hands frequently here, whether or not you have direct contact with patients with C. difficile. And that includes those of you working in dental practices. We'll talk about water after our break. All right, let's talk then about universal precautions. So that term changed to standard precautions to include other fluids besides bloodborne pathogens. But we treat all patients as potentially infectious, right? Patients with bloodborne infections can be asymptomatic carriers, unaware that they are infected. How do we reduce blood exposure? Through preventive practice, careful handling of sharp instruments, using rubber dams to minimize blood spattering, hand washing, and the use of PPE. In 1996, the term universal precautions was expanded by the CDC to standard precautions. And it's a standard of care designed to help us all and patients from pathogens that can be spread by blood or any other body fluid, excretion, or secretion. And it took to 1996. This is while I was in dental school. Actually, it was right after I graduated. But we weren't sure, for instance, if HIV could be spread through contact with saliva. Right, so this is when that notification, they were able to look at those studies and determine. So again, any other body fluid, excretion, or secretions. So probiotics are usually taken, some people take them all the time, like I did, right? You can also get probiotics from your food. We're talking at much greater doses, though, and I was recommended different probiotics while I had C. difficile. I was taking billions of CFUs. Elements of standard precautions include hand washing, PPE, disinfection of patient care equipment, disinfection of the environmental surfaces, and injury prevention. Let's talk about personnel elements of an infection control program. This can be a little dry, so we're just going through it. It aligns with the CDC, and I will make some recommendations as well. So personnel health elements include education and training, immunizations, exposure prevention, post-exposure management, medical condition management, work-related illnesses and restrictions, and health record maintenance. We develop a written health program for dental healthcare personnel, policies, procedures, and guidelines for education and training, immunizations, exposure prevention, again, post-exposure management, medical conditions, work-related illness and associated work restrictions, contact dermatitis, latex hypersensitivity, the maintenance of records, data management, and confidentiality, and establish referral arrangements with qualified healthcare personnel. We provide education and training to our team at initial employment when new tasks or procedures affect the employee's occupational exposure, and even new materials. At a minimum, annually, with education and training regarding occupational exposure to potentially infectious agents and infection control procedures. Protocols are appropriate for and specific to the assigned duties. Now, sometimes you have folks that float from the front to the back when needed. I certainly did. That means they all have to be educated to the same level. Provide educational information appropriate in content and vocabulary to the educational level, literacy, and language of that employee. Now, we are to develop a written comprehensive policy regarding immunizing our staff. It should include a list of all required and recommended immunizations, and we should have a referral to a qualified healthcare professional or their own to receive all the appropriate immunizations based on the latest recommendations, as well as their medical history and risk for occupational exposure. So, with that, not sure if you are aware of this, but there is software out there, credentialing software that you can use, and you can check with your practice management software rep. They may be able to guide you on this too. But there are several out there software available that you can have your employees on board. They upload their license, they upload their CE, for instance, they upload their vaccination records, they upload the last time they had the tuberculosis titer checked, and so forth, so that it's all in one place, and everyone that's involved, administration as well as that employee, will get a reminder, hey, your TB test is going to be due next month. It's really difficult to keep track of that on an Excel spreadsheet for multiple employees. And I found that out when I was with Maricopa County, because we had one poor hygienist who was in charge of keeping track of this for literally 60 or 70 people. And every day I would be looking at this and we were struggling to keep up with what was needed. So contact your practice management software, find out, and then you can keep all of this confidentially on a software program, on a platform, so that everybody's kept in the loop and nobody falls through the cracks. Our written policies regarding work restriction and exclusion should include a statement of authority, who is going to implement those policies, develop policies for work restriction and exclusion that encourage our team to seek appropriate preventive and curative care, report their illnesses, medical conditions, or treatments that can render them more susceptible to opportunistic infection or exposures. We shouldn't penalize our staff with loss of wages, benefits, or job status, and develop policies and procedures for evaluation, diagnosis, and management of dental healthcare personnel with suspected or known occupational contact dermatitis. So at one time there was motivation, and this was in many of the practice management consulting programs out there, that you could bonus your employees for not taking their sick time. So it would ensure that they came to work. But conversely, you'd have employees that showed up sick. And your patients really don't want a dental assistant or a hygienist or their dentist sneezing and coughing and sniffling in front of them, even when they're wearing a mask. They don't want to be around sick people in a healthcare office, and they will post it on Yelp or Google. Hey, I was in there, everybody in the office is sick, don't they go home? And so forth. That's the kind of information people want to post on Google about your practice. So stay home. All right, seek definitive diagnosis for any person who claims they have a latex sensitivity or allergy. Establish and maintain confidential medical records for your team, i.e. immunization records, documentation, and that's why credentialing software is really important. And ensure that your practice complies with all laws, federal, state, and local, regarding medical record keeping and confidentiality. I was brought in as a director of a dental hygiene program as a consultant. They ran into some compliance issues, and they were storing their student records. I'm talking their medical records in cardboard boxes in the operatories in their clinic because they didn't have any room. Unlocked, vaccine records, injury records and everything. So when I got there and I was going through the operatories and looking at things to make sure they were compliant, and I see these records, literally thousands of people's medical records just shoved in there, right? And all of that had to be scanned, and then those boxes had to be stored in a medical record storage facility. So that's why I say get a credentialing software. All right, preventing transmission of bloodborne pathogens. What are we worried about here? Some would be hepatitis B, hepatitis C, HIV. Transmissible in healthcare settings, can produce chronic infection and are often carried by persons unaware of their infection. Again, carriers. Now, when I was in dental school in 1990, was my freshman year, in San Francisco, HIV, as you can imagine, AIDS was a big deal in the city, and many of my patients had AIDS. They did not have a chronic infection, they died. And we had to treatment plan to the full extent because it was a learning institution, even though we knew that patient may not be here next month, 2 months, whatever the case may be. So it always shocks me when I see chronic infection on this slide because my patients didn't survive. And oftentimes, on 2 occasions, I had to deliver denture cases to funeral homes so that I could get my credit because my patient didn't survive the denture case because it took months in the dental school. So now it's considered a chronic infection for many. All right, potential routes of transmission of bloodborne pathogens, patient to dental healthcare personnel to patient, patient to patient. Infections can be transmitted through several routes. We talked about direct contact with the patient's blood, oral fluids, or other infected materials, and indirect contact with contamination. Factors influencing our occupational risk of bloodborne virus infection, the frequency of infection among the patient, the risk of transmission after a blood exposure, so the type of virus, not all viruses are as robust, and type and frequency of blood contact. So I had a needle stick in my junior year at UCSF at San Francisco General Hospital. My patient had AIDS. They had a CD4 count of 3. They had hepatitis C and D. They had cytomegalovirus. They had just about everything. And I was gloved, and I was performing endo on number 9 with one of those rubber dams that looked like Hannibal Lecter. You know, you had like 10 clasps, and the instructor made sure that every clasp was correct and no wrinkles, etc. No dental assistant. And this patient, because he had cytomegalovirus, had hallucinations. So he would laugh for no reason. He was hearing things. And I had to re-inject number 9, and he jerked his head back, and I stuck my finger. And it wasn't deep, but it was definitely a needle stick. Now, aside from my life flashing before my eyes, what happened? Well, they brought in Dr. Deborah Greenspan to counsel me. That was the protocol. They had me take what we called the cocktail back then. Many of my classmates had to. And it was frightening. You know, I questioned my profession at that point. It was a frightening time to be in dental school and be a do-gooder. Now, what was the frequency of infection among patients? Well, at that institution, it was quite high. Risk of transmission after a blood exposure, we didn't know in 1992. That's why we were there. We were part of the study. So we didn't know what the risk of transmission was going to be. We knew we were double gloved, and we knew it was a hollow stick needle. Type and frequency of blood contact, well, it was the oral cavity, which is vascular. And so, yep, you have blood contact. But let's look at what that risk would be now that we have the data that we didn't have in 1992. I'm looking, I have a classmate who's on here occasionally, a few classmates. Let's see if she's here today. Nope, she's not here. I have a couple of my former dental assistants on here too. All right, average risk of bloodborne virus transmission after a needle stick. So this was a comparison of hepatitis B virus, hepatitis C virus, and HIV. And what is the risk if you had a needle stick with one of these viruses compared to each other? So the average risk of an HIV infection after a needle stick or another percutaneous exposure to HIV infected blood is 1 in 300. 1 in 300 needle sticks from an HIV infected patient. On the other hand, hepatitis B prior to the vaccine and prior to PPE was a career ender for quite a few dentists because we were using, not using PPE. So our bare hands were going in mouths, right? Coming into contact with the patient's blood and saliva and so forth. And that, if you had a needle stick or any other percutaneous exposure, that risk was 1 in 3. So 1 in 3 for hepatitis B. The risk was 30% that you could become infected from a needle stick with a hepatitis B positive patient, and 1 in 300 with HIV. So it puts it in perspective. But we didn't know that at the time. All right, concentration of hepatitis B virus in body fluids quite high in blood, serum, wound exudate, moderate in semen, vaginal fluid, and low to not detectable in urine, feces, sweat, tears, and breast milk. The estimated incidence of hepatitis B virus infections among healthcare personnel and the general population from 85 to 99. So in 85, I was a dental assistant and entering undergrad. Now, at that time, that was prior to the vaccine, that was prior to PPE, the incidence of hepatitis B virus infection among healthcare personnel was much greater, as you can see, than that of the general US population. But because of wearing PPE, because of vaccine, you can see it brought these numbers way down from 87 to 89. And part of the issue that occurred here was AIDS, because it caused a lot of fear. And it also caused some doubt in the way we were performing our infection control in our dental practices. So things changed. We started wearing PPE, and we were getting vaccinated. So at UCSF, one of my professors, his lab discovered the hepatitis B virus vaccine. And they just lined us up all in the hallway one day, and we were given a series of 3. Now, you can see the incidence is below that of the general US population. It is a wise idea to get your titer checked now and then. Talk to your primary care provider. Hepatitis B virus infection among US dentists has declined overall because they've aged out, they've retired, and again, because of PPE and vaccine. How do we mitigate hepatitis B virus risk in the dental setting? Vaccinate all of our staff who are at risk of exposure to blood, provide access to qualified healthcare professionals, and test for antibodies 1 to 2 months after the 3rd dose, and make sure that you are retested again in the future, and there's no set time. So again, check with your primary care provider. Occasionally, we'll have non-responders here. If you don't respond to the first cycle or the first series, they may have you repeat it. But there are some out there that just won't respond to the vaccine. There were 9 clusters of transmission of hepatitis B from dentists and oral surgeons to patients from 1970 to 1987. 8 tested for hepatitis B were positive. Lack of documented transmission since 1987 probably reflects the fact that we now use gloves and we're vaccinated. There was 1 case of patient-to-patient transmission in 2003. Now, hepatitis C virus is inefficiently transmitted by occupational exposure. There have only been 3 reports of transmission from blood splash to the eye, and a report of simultaneous transmission of HIV and hepatitis C virus after non-intact skin exposure. So many of the patients that I saw that were HIV positive, that had AIDS, had also had hepatitis C, hepatitis D, again, cytomegalovirus and other things. Prevalence of hepatitis C virus infection among dentists was similar to that of the general population. It continues to be. No reports of hepatitis C virus transmission from infected staff to patients or from patient to patient. So the risk of hepatitis C virus transmission appears to be low. Let's talk now about HIV infection in dental settings. There's only one documented case of such from an infected dentist to patients, and that was the case of Dr. David Acker, who was a dentist in Florida who had AIDS. We'll talk about that. No transmissions documented in the investigation of 63 HIV-infected healthcare personnel that included 33 dentists or dental students. So Dr. David Acker, again, allegedly infected 6 of his patients with HIV, and one of those patients was Kimberly Bergalis, and this was while I was in dental school. So this was before the internet. This is when you got your news from watching the TV and reading a magazine or a newspaper. And Kimberly Bergalis was a young woman. He had extracted, I think, 3rd molars. Don't quote me on that, but it was an extraction. And she developed HIV and went on to have full-blown AIDS and died. And her parents took her to various congressional hearings and so forth to raise concerns about infection control. But also they were trying to have a law passed that made dentists declare their HIV status in public, that they had to. And that law, of course, never passed. Of course, you could be HIV negative today and HIV positive a week later, right? So logistically, it wasn't going to work. But the ADA and so forth went to bat for dentists and said, no, that's a huge invasion, not going to happen. However, this case was considered the first documented HIV transmission from a healthcare worker to a patient in the United States. The means of transmission was never known. So you can see that this came out very sensational. This was 1990, so it's when I entered dental school. And it made patients very fearful to go to the dentist, by the way, right? Especially in San Francisco. Okay, healthcare workers with documented possible or occupationally acquired HIV/AIDS over this from this database as of December 2002, 3 dentists, 1 oral surgeon, and 2 dental assistants. Risk factors for HIV after percutaneous exposure to HIV-infected blood: deep injury, visible blood on the device, needle placed directly in the artery or vein, and terminal illness in the source patient. So again, we didn't have this knowledge back in 1992 when I had the needle stick. Characteristics of injuries: reported frequency among general dentists has declined because we have protocols in place, right? Often caused outside of the patient's mouth by burrs, syringe needles, other sharps, involve small amounts of blood. Among oral surgeons, occur more frequently during fracture reductions and procedures involving wire. General recommendations: we use standard precautions. So OSHA's Bloodborne pathogen standard retains the term universal precautions for all patient encounters. Consider your sharp items that are contaminated with patient blood and saliva as potentially infective, and establish engineering controls and work practices to prevent injuries, and implement a written comprehensive program designed to minimize and manage dental healthcare personnel exposures to blood and body fluids. So engineering controls, work practice controls, and administrative controls. What are they? You're going to see some of those questions on your quiz. Engineering controls: we remove the hazard. We isolate or remove the hazard. So examples would be using a sharps container or using a medical device with an injury protection feature, like a self-sheathing needle or self-sheathing scalpel. Work practice controls: we change the way we perform the task so we don't put ourselves at risk. So for an example, I was trained to inject using my fingers to retract the tissue and palpate for anatomical landmarks, right? Now, my 3rd year of dental school, the professor said, we're not going to do it that way anymore. We're going to have you use your mouth mirror to retract and palpate anatomical landmarks when you're injecting. So we're trying to we're trying to change the way we perform the task to reduce the risk. And one-handed needle recapping would be another example. So it's required that we identify, evaluate, and select devices with engineered safety features at least annually or as they become available on the market. We use sharps containers for our sharps, syringes, needles, scalpel blades, other sharp items. We do not recap used needles by using both hands or any technique that involves directing the pointing of the needle toward any body part. And we don't bend, break, or remove needles before disposal. That sounds like common sense, but in 1981, that's exactly what we did. So I was trained to take my bare hands, first of all, bend the needle. So I'd take the syringe, I'd bend the needle. Then I'd take my bare hands, screw the needle off the hub. Then I throw it in a milk container and I pour it up with plaster after that milk container becomes filled with contaminated needles. And then we throw it in the dumpster. That was our sharps control program in 1981. So you can understand why things needed to change, right? Now, they even sold these devices where you could chop the needles up first with your bare hands and throw those pieces in the milk carton first before you pour it up in stone. Use a one-handed scoop technique or a mechanical device for needle recapping. So there are little cardboard holders. There are also the heavyweight metal holders as well. So in the 1970s, we only gloved for Asian patients. We were told that Asian populations often carried hepatitis B. When I was practicing, we got one glove for surgical procedures as an assistant on the left hand, and we autoclaved those gloves in a Harvey Chemclave. So you'd open that glove up, it was like a balloon, and then try to get your hand in it for the next procedure. It was kind of ridiculous, and they were stained brown from the ethylene oxide and so forth. It was a bad deal. So the protocols needed to be in place. Joan, I'm not sure what to do if you can't toggle. If you're on a phone, I can't do anything about that, unfortunately. So does hepatitis B virus have higher transmissibility than HCV? That's hepatitis C. It's on the quiz. What do you all say? I cannot provide you with medical advice about a tetanus shot. You need to check with your primary care provider. Okay, let's go to administrative controls, policies, procedures, and enforcement measures. These are placed in the hierarchy of all the other controls. You all are the experts on administrative controls. At the beginning of the pandemic, what were you doing? You were making sure that you're trying to make sure that trouble never walked in the door, right? So you had your patients, of course, filling out their forms online, their health history, asking them questions. Have you tested positive for COVID-19? Has anyone in your household? Have you traveled? Blah, blah, blah. You were taking temperatures. You had the patient waiting out in the car and texting you when they arrived. You maybe only had patients in the practice, no family members. All of those are administrative controls because you're trying to prevent someone who is possibly infected from coming into your practice and infecting everybody else. That doesn't necessarily eliminate the carriers, though. So many of you were rapid testing patients for COVID-19 as well. These are placed before engineering controls for airborne precautions as well. All right, post-exposure management program, clear policies and procedures, education of your team, rapid access to clinical care, post-exposure prophylaxis and testing of the source patients. Excuse me. And we follow the CDC recommendations that we just discussed for sharps. Injuries. Post-exposure management requires wound management, exposure reporting, assessment of infection risk. So the type and severity of the exposure, the bloodborne status of the source person, and susceptibility of this exposed person. All right, aerosol management. And we are going to transition over to Glory's presentation. So again, we finished part one just about. We will have part two after her presentation. So please be sure that you are here. Importance of aerosol management. This is the feds in light of the SARS-CoV-2 pandemic. The US OSHA have classified dentistry as one of the very high-risk occupations for transmission of the disease because of the aerosols produced. Newsflash, it existed before SARS-CoV-2. But SARS-CoV-2, COVID-19 brought this to light, right? It brought us to light that this is an issue for us. Aerosol is an occupational exposure for us. Ultrasonic scaling can transmit particulate aerosol for up to 6 feet, and without an air current, it can remain suspended from 35 minutes to several hours. And if it's over 10 microns, of course, those are the larger particles, the spatter. Gravity will cause those to eventually settle on your surrounding surfaces. Could be the patient tray, could be your arms if they're not covered, could be your hair if it's not covered. External high volume extraction in this study conclusion using such reduced the aerosol particle count of all sizes significantly. Gloria is going to talk about that as well. And any questions from this morning that I didn't get to, I will definitely readdress here. So with that, we are going to go ahead now and start into Gloria's presentation, and she is then going to answer any questions for you. So we're going to go ahead and get that queued up for you. In the meantime, if you do have any questions from this morning, please make sure that you let us know by typing into the chat area. Okay, at the top of the screen is a blue banner that will take you to IQAir. And I want to introduce you to Glory. And before that, we do that, we're going to show a quick demonstration video. Glory Dolphin-Hamas is the CEO of IQAir, North American division, a Swiss-based air quality technology company. She's a certified indoor environmentalist and a licensed HVAC contractor specializing in air quality. She's also a member of the EPA's Air Quality Work Group. She resides in Southern California with her husband, Frank, and 2 sons. And I'm going to show you a quick demonstration video of Frank Hamas. And this video, they actually shoot a hand grenade into this chamber, and you can see how quickly their air filter will clear the air. It's within literally seconds. And again, at the top of the screen, you'll see the banner.
IQAir President Frank Hamas is about to step into this specially designed chamber to personally prove the effectiveness of the IQAir Health Pro Plus. We have 2 officers here to ensure the grenades are properly fired. Now, obviously, this is a demonstration you don't want to try at home. We're about to release noxious smoke and chemicals into this chamber. Your home can be filled with harmful fumes from household cleaners and other pollutants, but nothing compares with what we're about to release. Now Frank is sitting close to the IQAir and will only breathe the fresh filtered air coming directly out of the Health Pro Plus. Remember, he doesn't have a gas mask. The whole chamber is now filled with noxious smoke and chemicals. Look closely. You can see Frank breathing the clean air stream coming directly from the Health Pro Plus. the IQAir Health Pro Plus is clearing the room completely.
Everything good, man.
Let's talk about solutions for dental practices, how to improve the air quality in dental offices, operatories, and waiting rooms. The execution of dental work increases the risk of exposure to a wide range of potentially harmful airborne contaminants such as viruses, bacteria, and also other dangerous aerosols. That means that the risk of airborne exposure to airborne pathogens the risk is significantly higher than in most environments. And it's really that the use of high-speed drills, ultrasonic scaling, equipment generates fine droplets, also ultrafine droplets, essentially aerosolize particulate matter that are light enough to stay in the air for hours and sometimes indefinitely. Particle size does matter. In terms of sheer volume, it's actually ultrafine particulate matter that make up over 90% of airborne particles. Fine particulate matter accounts for about 9% of airborne particles. So fine particulate matter that is between the size range of 0.1 microns and 1 microns. Then you have really coarse particulate matter, and that accounts for less than 1% of all airborne contaminants that are in the air. Let's take a look at this video. This video shows essentially what the air quality looks like in a 10, 15 minute procedure. So what we can actually see with the naked eye is coarse particles. So we actually cannot even see fine particulate matter with the naked eye. And let alone ultrafine particles, which account for over 90% of particulate matter in the air. And what that means is that there's a whole lot more particulate matter when you're talking about counting fine and ultrafine particulate matter, because the only thing that we can see with the naked eye is the coarse particulate matter. So that this just shows that we're actually only seeing 1/100th of the particulate matter that's there in terms of sheer volume. Okay, there are actually 3 steps to improve air quality. First step is source control. And by the way, I'm actually presenting these steps in order and prioritization order of importance. So if there was only one thing that you could do and one thing alone, you would want to do source control. So this is a prioritization order, and I get this list. This is not my personal list, but this is actually the list coming from the Environmental Protection Agency and what to do to improve air quality for all types of environments. So number 1, you'd want to do source control. Number 2, you'd want to ventilate. Ventilation is also known as dilution. So when you think about ventilation, think about diluting the air and introducing a new source of air into the room to dilute the amount of concentration of particulate matter. Also, step number 3 is recirculation or air cleaning. And often, even through the pandemic, the first thing that we actually thought about was actually air purifiers and getting an air purifier in general. But as we see when we look at this prioritization list in terms of improving air quality, that is actually number 3. And we should be really, truly looking at source control and also ventilation as well. When it comes to source control, wanted to mention that extraoral suction. You probably heard of that within the dental environment. Extraoral suction allows aerosols to be captured at the source. And just a little bit step further, in terms of air quality and improving the air quality, you've got to start with measuring the air quality. We've got to actually quantify how clean, or in some cases, how dirty the air might be. That's what we do with the Air Visual Pro and also with the Air Visual Outdoor. It is our air quality monitoring platform, and it's very important that you, as a facilities owner, that you understand where the state of your air quality actually is, so that you can improve it and make it better at all times. So that's what this actually allows you to do. And what we do in terms of air quality, we actually measure outdoor air quality, and that's what's called baseline. And it's always good for us to clean the indoor air, and we compare it to the outdoor air. How much cleaner is the indoor air in comparison to the outdoor air? Good question. I'll answer that. We have clean air facility. This is our particular clean air facility in La Mirada. This is IQAir La Mirada, and you can see how much cleaner the indoor air in comparison to the outdoor air is, and it's 100% cleaner. With the clean air facility, you're able to achieve approximately 90% cleaner air, and that's according to baseline outdoor air. So we're going to talk a little bit more about source control. First, you measure the air quality to understand where you want to be in terms of air quality. But when it comes to the dental environment, in terms of source control, you actually want to remove the source of airborne particulate matter as it's being created. And that's through the use of a device. It's called an extraoral suction device. And it actually vacuums away in a suction-like manner the particulate matter that is being created, and it does this as the particulate matter is being created. So this is a very important tool. With our IQAir FlexVac, we're able to achieve 90%, actually 92% effective capture rate when this device is within 12 inches of the patient's mouth. And that's a very big improvement in the air quality and removing what's being generated in terms of aerosolized particulate matter. So we just spoke about extraoral suction. This is a picture of extraoral suction device. There, the FlexVac. The other way to improve air quality through source control is through the use of the Air Visual Pro. By being able to measure, you're actually able to make procedural improvements. You're able to see what would make the difference in some cases if you add water spray, if you add certain steps, and I'm sure that will be talked about in detail. And these different steps that you can do, these can create quantifiable improvements in the air quality. And I know that there's quite a few dentists that experiment with this, and you're able to do that with the Air Visual Pro. You're able to go from room to room. You're able to measure before the procedures, after procedures, and it's able to really give you quantified details in terms of how the air quality is doing and what improvements you can make that result in producing less aerosolized particulate matter. Okay, so rule of thumb is that extraoral suction is the key. We do have procedures that produce aerosolized particulate matter, and it is important as that particulate matter is being created that it's literally being removed from the air as it's being created. And we know that we can do that with a 92% capture rate on the IQAir FlexVac. Procedural improvements also go a long way. So please keep in mind that there are procedural improvements that you can do that help to minimize the release of particulate matter in your procedures. Step number 2 is ventilation. So if there's access to the HVAC system, we have induct ventilation, we have induct filtration, the Nanomax system that's installed, and this provides mechanical ventilation as well as filtration, and it's a great option if the building, if the building has HVAC. It's a great option. If there's an older building, then mechanical ventilation is the option, and that's opening your doors and your windows, introducing an outside source of air. Step number 3, air cleaning, placing an adequate amount of air purifiers within the waiting room. One Health Pro Plus will be able to cover an 1,150 square foot space. So that's also something to keep in mind when it comes to air cleaning. So our solutions engineer can help to assess your practice and provide a solution report to achieve 90% cleaner air with our Clean Air Facility program. Great. Ventilation, HVAC or mechanical ventilation. Let's talk about that in detail. We have a product, it's called Nanomax. It actually is able to achieve better than MERV 16 filtration. It's able to do that because it has a pretty high surface area, lots of pleating surface, and it provides a low pressure drop across the filter, and it works through the HVAC system. It's essentially a 2-inch filter. And with this 2-inch filter, you're able to have just a pretty substantial increase in airflow. If you've had a MERV 11, MERV 13, this Nanomax filter is able to have a lower pressure drop than most MERV 11 and MERV 13 filters, but providing a higher efficiency through the technology that it incorporates. Great. And in terms of step 3, we're looking at air cleaning and recirculation, and it's important that we don't forget about the 8% when we're capturing at 92% rate. There's still that 8% to think about, and how will we be able to remove the aerosolized particulate matter from our procedures when we're only capturing 92%? What happens to the 8% that's floating around? That's what we do when it comes to air cleaning and recirculation. Great. This is Dr. Garcia's orthodontic facility in Miami. Nice office there with the nice lighting, and you can see there the Health Pro Plus in the waiting room. Great. This is his practice and what it looks like, and this is an open bay system that he has here. He has the dental HV flex back, and as he moves from patient to patient, he is using the extraoral suction device in order to remove the sources of particulate matter when it comes to aerosolized biocontaminants. Great. This is Dr. Kelly Blodgett, and he's also working with the IQAir Flex Vac with a patient, and it is really in a good space when it can be 12 inches away from the patient's mouth, and you can see the patient is also pretty happy with that as well. Great. Any comments? I'd love to hear your feedback as well. And you can also visit our dental solutions page and reach out to us, and a solutions engineer will be able to help you. You can also schedule a call as well, and folks will be able to help you and give you a 10 or 15 minutes, if you have 10 or 15 minutes to spend with them, how you can achieve cleaner air within your facility. Thank you so much.
Hi, Glory. Welcome.
Hi. Thanks for having me.
Good to see you. So we have a large group today, and they are feisty with questions. We've had great questions today. So this was a question that Paula asked earlier. Some offices don't have air filters, so no open windows. What can you do?
Well, if there's no open windows, no air filters, you really do want to introduce some form of HEPA filtration within the office. It's real important as there is a continuous. Every procedure will actually produce pretty high amounts of particulate matter, and so there'll be a buildup if there's really no sort of a way to filter that through recirculation or through extraoral suction. So it's really a good thing to have to continue to have air filtration running, HEPA filtration running throughout the workspace.
And good source control initially, right? So try to remove as much as you can possibly for every procedure, since you have no ventilation and so forth, right?
Yes, first and foremost is the source control and the extraoral suction.
Okay. And then what, if any, future requirements will be mandated for operatory air quality? Do you have any information about that?
I don't have any information because I'm not on the regulatory side, but just with regards to the air quality side, I do hope that there is some regulation because I think it will protect health. It's definitely going to be something that would protect human health in the future.
How much space does it take?
I think working space, it's definitely needs to be within 12 inches of the patient's mouth. But then with regards to space within the room, it's about like a 2-foot area, so about 24 inches squared there, and about 30 inches high as well.
Can you talk a little bit about UVC lighting and how it affects the HVAC and so forth?
Oh, sure. There's different types of UVC. I've seen UVC within the dental operatory, and I've seen UVC within the HVAC system. So UVC within HVAC system is generally placed on the fan coil, and it's there to prevent mold growth. So really what UVC has been highly effective at doing is killing germs on the surface, and that's why when you talk about UVC, there's always this emphasis on the kill rate. So there needs to be a sufficient amount of contact time in order to get what's called a high kill rate, high rate of efficiency. When I've seen UVC within the dental environment, it was really not in a good utilization because it was just within the dental operatory. And what happens there is it will kill whatever biocontaminants might be on the surface at a specific kill rate. But in terms of the air that's just passing through, the contact time needs to be there. And there isn't a sufficient amount of contact time in order to have a high kill rate, basically.
Thank you.
Mhm.
I wanted to go to the slide about air quality monitoring because I think it's important, even for Paula's question about what do you do when you don't have ventilation, and maybe also look at some of your procedures to see, maybe introduce rubber dams, and extraoral suction was the device that Gloria was talking about earlier, your source control. But also being able to monitor your air with the Air Visual Pro and the Air Visual Outdoor. So you may see, you heard Gloria talking about, looking at procedures and see if there's something you could alter a little bit that can make a big difference. And this is the way to do it. Very cost effective. You can see the quality of your air in your practice, and you might be surprised.
Yeah, this is actually a great way to get people oriented around air quality is first start with this awareness level and understanding where your practice might be in terms of air quality, getting an average, comparing that to the outside, and slowly over time being able to improve the air quality more and more. And you can get essentially quantifiable results in how clean and how dirty the air is. And this is the really great start to become more familiar with air quality.
And the air quality alerts, so that you have filtration that turns on when there's a certain threshold, I guess, that you hit. That's pretty good, because
Yeah.
I have to have reminders. How loud is the extraoral suction, Glory?
That's a good question. Our extraoral suction for IQAir is actually not louder than the devices that are being used, if that's the ultrasonic scale or the drills. However, there are some extraoral suction devices that are louder, and we've just come from a very the background that we have in terms of air cleaning and air filtration. We work a lot within schools and within very noise sensitive environments. So we are definitely conscientious about creating solutions that are not louder than the instruments that are being used within the operatory.
Excellent. And if they contact you, so I want to remind everyone, at the top of the screen, there is a banner, and it will take you to IQAir to learn more and contact them. What is the next step for them? Do they get a call back or Zoom call, or how does that work?
Sure, depending on the way that the person fills out the form and wants to be contacted, that's how we will in turn contact the person. So sometimes they want to set up a Zoom call so that they
Okay.
can walk through, or just do a phone call.
Okay. And also, I want to remind everyone that a copy of this presentation is in your course folder with contact information to IQAir. Are there any other questions for Glory? All right. Well, if not, definitely reach out to IQAir. And thank you, Glory, for your support and all of your expertise today. We really enjoy having you.
Thanks for having me.
Thank you.
Have a
Now,
good one.
you
Thanks.
too. Bye-bye.
Bye-bye.
All right, everyone. Again, this presentation is in your course folder. You can also bookmark that URL when you tap on the banner at the top of the screen where it says tap here, and save it to your device and take it back to your practices on Monday. I know there are a few of you in here that have IQAir already, and they also have devices for your home as well. So home, your vehicle, your office, tabletop devices, and so forth. But the monitoring of your air quality is so important, and their device is not quite $300 to do that. So, and it can connect with all of your other devices in many cases. So thank you all for staying on here today. And if you have any questions from this morning that I may not have addressed, please go ahead and type them in the chat area. I'm going to see how many minutes we have left here. Lisa, you might have to use another device. Printing would be a property of your device. It wouldn't be something that we have control over. Passcode is done at the end of this presentation. You'll also get the course folder. Hang on to the link and just use a device maybe at your practice. You have multiple attempts on the quiz, yes. I'm going to repost the instructions from this morning. And we'll put the call to action banner back up. Okay, so I've just posted in the chat area one more time how to receive CE credit, information about the passcode if you joined a little bit late. So there's a link to the quiz right there. You can also go to our website, dentalceacademy.com/quiz. Download the handouts for that link, and the passcode I will announce at the end. If you happen to be watching this later on another date other than March the 15th, you are watching a recorded lecture. You'll receive your CE credit a little differently. You'll scroll below the video player on the website to the instructions section and follow those instructions for the quiz as well as the handouts. Passcode not announced yet. All right, we're going to talk about effective hand hygiene in just a couple of minutes here. Any questions from earlier today? All right, we're going to talk about effective hand hygiene. Now, this is a course that I spend a whole hour talking about, and it's on our website right now, available on demand, and we do offer it live from time to time throughout the year. Hands are the most common mode of pathogen transmission when we looked at the chain of infection, right? Whether or not we're wearing gloves, reduces the spread of antimicrobial resistance and prevents healthcare associated infections. It's to protect you and protect your patients. There are two types of microbes, the resident microbes and the transient microbes. Now, the resident microbes represent the normal microflora that everybody has on their hands, always present on the skin, always within the first layer of the skin, which is multi-layered, the stratum corneum. So calluses and so forth, multi-layered, right? You get pathogens that get, or microflora that get embedded in those layers. So it's impossible for you to remove all of them. So we have to scrub those areas for surgical procedures, right? Now, the transient microbes are the hitchhikers. Those we pick up from patient contact or contaminated surfaces. And this can pose a significant threat because it potentially contains every form of disease-causing agent that the patient carries. Now, the concept of hand washing and surgical scrubbing is to reduce the amount of resident microbes present in the stratum corneum as well as the transient. So to do that, we use antimicrobial soaps for surgical scrub or regular soap and water and an antimicrobial gel with persistent activity. We're going to talk, for the most part, our garden variety dental procedures, restorative procedures today. We need to perform hand hygiene with either a non-antimicrobial or antimicrobial soap and water when hands are either visibly dirty or contaminated with blood or OPIM. If hands are not visibly soiled, we can use an alcohol-based hand rub. Now, Understand that neither soap and water or alcohol-based hand rub will kill Clostridium difficile spores, by the way. But we do say frequent hand washing, right? And the reason is that if we're washing our hands under running water with soap, we can help flush anything on our hands off. If we're just using alcohol-based hand sanitizer like this, we're just rubbing the spores around. So hospitals are rethinking this when they have a Clostridium difficile outbreak. And if you've ever had C. difficile or you've ever known someone that's had C. difficile, you are in an isolated room. Anybody that comes in to see you has to scrub and gown up to be able to go in the room, and then reverse that process when they walk out. They're going to take off that disposable gown, mask, gloves, and wash again because it's highly contagious. So alcohol-based hand rub has its applications, though. I've used it in mobile programs many of the times when I don't have sinks, and many dental practices now don't have sinks, right? But you want to use it correctly. So I don't know if you can see this here. Not good in this one. Anyways, many of us will use it like it's a hand lotion. Put a little bit here, and then we do this, right? And then we put our gloves on. That is not effective hand hygiene. So if the bottle tells you to use it for 20 seconds, believe them, because otherwise it's not going to be effective. If your hands are drying in 5 seconds, you may not have applied enough. You certainly may not have accessed all the surfaces that you needed to, and it may not have come into contact with the surfaces of your hand long enough. So always follow your manufacturer's instructions, and always follow your manufacturer's instructions for anything in your practice. So if you have been given the responsibility, for instance, to maintain your autoclave or your water lines, and you've never seen the instructions for use from the manufacturer, you're working blind, right? So you have to contact the manufacturer if you need to, get on Google, find those instructions for use so that you know you're performing the maintenance correctly for that particular device. All right, indications for hand hygiene include when hands are visibly soiled, after we touch inanimate objects or contaminated objects with our bare hands, before and after we treat every patient, before we put our gloves on, and immediately after we take our gloves off. So when we take our gloves off, instead of throwing them on the countertop or on the patient tray, directly in the trash if you can. Skip any potential cross-contamination that you may cause with those gloves. For oral surgical procedures, we perform surgical hand antisepsis before we don our sterile surgeon's gloves. Follow the manufacturer's instructions for antimicrobial soap and water, or the application of an alcohol-based surgical hand scrub product with persistent activity. Good hand care practices are an important part of reducing the transmission of disease in the dental environment, and hand care practices should include the following: hand cleansing procedures, hand care products to maintain healthy skin, and the use of gloves. Areas that we commonly miss. So the dominant hand. If you are right-handed, you probably aren't paying as much attention to the right hand as you are the left hand. So on the back of the hand, we tend to miss, you see the area in purple, the thumb, the nail beds, the tips of the nails, and between the fingers. On the palm of the hand, you can see the area that we miss on the palm, the wrist, fingertips, and between the fingers. Hand hygiene in a healthcare environment is a cultural practice. And if your team does not see the owner dentist or the associate dentist performing effective hand hygiene, probably the staff will start to not pay attention either. And that's unfortunate because, as we said, hands are the #1 mode of transmission in any healthcare environment, and your patients are watching you. If they don't see you performing hand hygiene, if they see you handling their instruments with bare hands, regardless or not if you've washed your hands, these are the things they notice now on Yelp, and we're going to be looking at a few Yelp reviews. So if you want referrals and you want new patients, perform your hand hygiene right in front of the patient. Make sure that your patients know that infection control is of the utmost importance in your practice, and demonstrate it. I'm going to show you a quick video here. This is called the purple paint hand washing demo. And there are quite a few of these on YouTube. Now, there might be a few of you that cannot hear this video today. You have the link in your handout, or you can just go to YouTube and you'll see quite a few of these. So this is a nursing instructor. She's wearing gloves. She's not washing her gloves. She just doesn't want her hands to turn purple. I'm using purple body paint, and she's going to show you a 1-minute process for effective hand hygiene.
Let's first put soap in the palm of our hands and then begin to rub in between like so. But as you see, there is no soap on the back of my hands, so I'm going to interlace my fingers palm to palm, and then I'm going to do the same technique on the back of my hands with each hand. And then you're going to take the back of your fingers to opposing palms with fingers interlocked. And then start rubbing your thumbs. And then you're going to take your fingertips, clasp the fingertips in the right hand in the left palm, and vice versa. Rub your wrist one last time to make sure your hands have been completely covered in soap. Thanks for watching.
Okay, so we have someone here who works in a hospital and had made the comment that hospital protocol in hospitals, hand washing only, no hand sanitizer, and C. diff contact rooms. So I'm APIC familiar with a lot of this. And the fact is, and Tosh, I'm going to share this with you, and it probably won't be any surprise to you. And when I was in the C. diff rooms, yes, they cannot use alcohol hand sanitizer. They have to wash with soap and water because it's not effective against the spores. I was hospitalized about 1.5 years ago for vertigo, and I was kept overnight for observation. And every nurse that walked into my room, I had to remind them to either use alcohol hand sanitizer or use a sink to wash their hands. Every single nurse that walked into my room walked past a sign that said that you had to effectively, or the terminology, wash your hands upon entering the room and upon leaving. And I was in an observation room that was shared with another patient, which is a whole other story. And the nurse would walk in, I'm here to flush out your IV, and would pull 2 gloves to come over to my IV. And I'm somebody that already survived one healthcare associated infection. I'd say, well, you're not touching this IV until you wash your hands. They'd walk right past the alcohol-based hand sanitizer, nurse after nurse after nurse. So when I got home, I called the hospital. And by the way, for you all in Phoenix, it was Banner Hospital. And I said, what is going on with your staff that they're going to come in and flush an IV line and not wash their hands? You know, just grab a couple of gloves after they've been on the computer, and then after they've been on the patient next to me, which, by the way, had an infection that was not responding to antibiotics. She was a diabetic. So gosh only knows what that was, right? And then on top of it, 4 days later, I came down with COVID symptoms, and I had COVID for 3 months. So I was not happy with the protocols in that hospital. And that's why I say patients are watching you. Patients are watching you. Even when I asked to be moved to another room because the patient was coughing all night long, they didn't have the staff to that. Right. So it was not a good situation. So you have a way to turn this around in your practices, because your patients have choices. If they don't like the way you're doing things, we all know they're going to go somewhere else and they're going to tell 10 friends. And nobody should have to tell their healthcare workers to wash their hands. Okay, question here. Going back, I'm going to hold your question, Mary. We'll have a review at the end. Some of these we're getting a little ahead of ourselves. My hands are terribly chapped from frequent hand washing and sanitizing. Is there a lotion you recommend? I like Glove and Care. And I also, at nighttime, I use a Eucerin product for very dry hands. And Eucerin is EUCERIN. I'll put it in the chat. I'll coat my hands with that at night, and I wear moisturizing gloves so that it really soaks in overnight. And that seems to help, especially around the nail beds and so forth. You may have to look at your products and see if there's something that you want to change up in terms of your products that may be too drying for you. I think, when gloves got introduced, there's a feeling that gloves protect us and we don't really need to go through this process, but you do. All right. Also of importance here is the type of soap that you use. And I'm not going to spend a whole lot of time on this, but if you use these types of containers, this one or this one, any of these three, unfortunately, because of these nozzles, there is biofilm that can grow inside of these containers. And studies indicate that about 25% of these or more are actually contaminated with fecal bacteria like norovirus, staph, streptococcus, so infections that can cause eye infections and so forth. And not just because you may or may not be topping them off. It's because of biofilm. Biofilm's stubborn. As you know, it grows in our water lines. It grows in our mouths. It's nature's way of defending bacteria from what we're trying to do to kill it. So, antisepsis, oral rinses, whatever the case may be, creates this biofilm. It's a protein matrix. Unfortunately, if you look in these, and Starbucks uses a lot of these types, you look in that little dial, it's green and black, there's a reason. You don't want to use that on your hands. So the most significant risk of microbial contamination due to the biofilm formation caused by hands touching the nozzles. You can't sterilize the nozzles between patients. You can't barrier wrap them. So you should really go to a dispenser that is hands-free. And when we say hands are the number one mode of transmission, we mean it. And these systems all require your hands to touch something. I'm going to show you a quick video. There's two quick videos I'm going to show you back to back here. This is Dr. Gerba, Charles Gerba. He's from, or was from, the University of Arizona. I'm not sure if he's still there or not. He talks about bulk soap dispensers.
You're most likely to come in contact with fecal bacteria with a refillable soap dispenser than anywhere in a public restroom. Because you really can't tell contamination's occurring. You can't see the bacteria growing in there. So you never really know if there's bacteria or not. That's why using a sealed soap dispenser is the way to go. Well, it's been found that really cleaning regular refillable soap dispensers doesn't really get at the bacterial problem because biofilms develop inside these soap dispensers. And even if you clean them and disinfect them, it comes back right away, the bacteria. As soon as you put additional soap in these dispensers, the bacteria start growing right away. Well, I think there's definitely a risk to people getting ill from refillable soap dispensers because you find bacteria in there that can cause eye, skin infections, and wound infections. So I think the probability is there. And of course, it's been demonstrated in healthcare facilities. So we know the potential is really strong for this to occur. People are going in there to remove things from their hands and they're putting them on. They're trying to take off fecal bacteria by washing their hands, and they're actually putting them on. So in a way, it's an oxymoron. You're doing the reverse of why you're washing your hands. Well, I really think bulk soap dispensers should be regulated. And in fact, I don't even think they should be used. I think we really should go to sanitary seal soap dispensers that you can't refill all the time, because that would eliminate the problem of the growth of the bacteria in these dispensers. But I think it's really the responsibility of facility management is to put the proper type of soap in these facilities so people don't increase their exposure to large numbers of bacteria. The greatest exposure to fecal bacteria for many people may be washing their
Okay, so there may have been a couple of you again that cannot hear or maybe cannot see the video because we're playing it on a YouTube player and you may have something conflicting in your browser. But we do have the links for you in the handout as well. Study indicates 1 in 4 refillable bulk soap dispensers is contaminated. Hands can have up to 25 times more germs after washing with contaminated soap. Now, you would think, well, I'm going to be flushing out my hands under running water anyway, so what's the big deal? And it also counts for alcohol-based hand sanitizer in bulk soap dispensers too. You can get biofilm in that. The big deal is that you don't know if you washed everything off. So why introduce a pathogen that may not have been on your hands to begin with, like norovirus, C. diff, and so forth, right? It's best to be safer than sorry. And I don't know how in dental practices we got into this sort of habit of using soft soap dispensers and so forth anyways. But you do want to go to automatic sensor controlled dispensers. And this is just a generic representation, but you can get the soap in antimicrobial or non-antimicrobial soap, and the hands do not touch the nozzle. So it's a safer way to perform hand hygiene. Again, this photo is a great representation here because they have pedals for the faucet, which is great, foot pedals. So your hands aren't touching the faucet when you're washing your hands. Beautiful. But they're using this Bed Bath & Beyond soap dispenser that is probably very contaminated. So remember to wash your hands when they're visibly dirty, after touching contaminated objects with bare hands, before and after patient treatment, so before glove placement and after glove removal. And using gloves can complicate the situation because remember, we have some bacteria that will remain in the embedded layers of our hands. And when we wear gloves, it's a dark, damp space for that bacteria and other pathogens to continue to multiply and replicate. And when you take your gloves off, they're contaminated, right? And so are your hands. So you have to wash your hands or apply hand hygiene after you remove your gloves and before you put your gloves back on. So use hand lotions to prevent skin dryness. We've had great recommendations here from so many of you. Thanks for posting those. Consider the compatibility of the lotion you're using and the antiseptic products and the effect of petroleum or other oil emollients on the integrity of your gloves. when you're selecting your gloves, check with your manufacturer. They can also give you recommendations. Fingernails should be kept short and smooth. They should be filed smooth so that you don't accidentally tear your gloves. And you want to be able to clean your gloves. One thing that I used to do was, especially, I've got some temp hygienists on here too. So little bit of my wiseness I'm going to share with you. I used to carry toothpicks, round polished toothpicks. At the beginning of the day, I would clean under my nails and my cuticles before I started my day, and at the end of the day, all right, just to make sure that my nails were clean before I started my day. We used to have brushes. The brushes are so contaminated. Get rid of the brushes. Don't use those anymore. Artificial fingernails, not a good idea in a healthcare practice. Not only can they contaminate, but they can be porous. They can start to lift off. We've seen some nasty fungal infections from those. What about gel nails and nail polish? So if there's no chipping, then that is deemed to be safe. We don't wear hand or nail jewelry if it makes it difficult to get gloves off or on. In fact, some state dental practice acts say no jewelry under the gloves at all. I wore my ring around my neck because I just didn't want it contaminated anyways. And you don't really have the time to fully decontaminate your ring between patients. So the soap is not actual soap, but dangerous substance. No, it's soap. But what's happening, Janet, is that when you're using the pump, you know, backflow that we have in dental lines, water lines and vacuum lines, you can get a type of backflow going on where the hands are touching that nozzle. It contaminates the nozzle and creates biofilm in the soap container. So that bacteria continues to reside in that soap, and then now you're applying it to your hands. What's the protocol for drying hands? Well, paper towels, loose paper towels, or if you have a sensor paper dispenser. Yeah. So I mentioned nail polish. The fake nails, I do not recommend in a dental practice at all, just because of what it can do to you in terms of infection too. Do you think public restrooms have biofilm in their soap dispensers? I know that public restrooms have biofilm in their soap dispensers. In fact, many of them, if you go into airports now, dental laboratories, if you're going for a blood draw or something, they've all changed to touchless, even some of the hotels and so forth. So I don't ever use those types of dispensers in any public setting. I carry my own alcohol-based hand sanitizer in that situation, which isn't perfect, but as my mother would say, it's better than a poke in the eye with a sharp stick, right? You did not miss the passcode, which tells me you don't have the instructions, so make sure you scroll up and get those instructions. Do you think public restrooms? Okay, we answered that one. Okay, let's go to PPE. I don't recommend the automatic air dryer machines, Nicole, because of the aerosols that are produced. Paper towels. Paper towels. Okay, we're going to finalize our last hour here. PPE should be no mystery to you, and I had a question about scrubs. And I'll address that in just a second here. So always wear a surgical mask and eye protection with solid side shields or a face shield to cover the whole face. Many of you may still be using N95s right now, which is fine. Just use a medical mask, medical grade mask over top of it and change that. If your mask does become wet, you do need to change it. Clean with soap and water your face shields. So the face shields at one time were meant to be disposable, but they're expensive. So if they're not scratched up and so forth, you can certainly wash them and disinfect them. Protective clothing. So your forearms need to be covered chairside. Now, if you are wearing scrubs, you'll wear a disposable gown over top of that. Maybe you're using laboratory jackets or you're using laundered gowns. Not every state requires dental practices to provide scrubs. Not every state requires dental practices to launder those scrubs. And you might be in one of those states. So if you are required to bring your own scrubs, I would recommend that you change at work. And then before you leave, you change back into your street clothes and throw those scrubs in a plastic bag and keep your scrubs separate from your household laundry. We're going to watch a video here shortly. Why? Because the contamination that you are exposed to in the healthcare environment doesn't stay in the healthcare environment. It's like Vegas, right? Or it's the opposite of Vegas. It doesn't stay in the healthcare environment. It's going home with you. It can go home on the bottoms of your shoes. So you want to make sure that you wear shoe covers or leave your work shoes at work. Your scrubs should be laundered with very high heat, and you can use Lysol laundry sanitizer. And by the way, in your course folder is a list of recommended technologies that I personally recommend. I don't receive any monetary reimbursement for those recommendations, but hot water, Lysol laundry soap. Okay. Now, we used to wear white scrubs, so they were bleached, but you all are wearing colored scrubs now, and you may not want to bleach them, although there are companies out there that have colored scrubs that can be bleached. Keep it away from your household laundry. Any clothing that you're wearing that is penetrated by blood or other OPIM, you should change immediately. And the CDC recommends that you change those disposable gowns or your overgowns at least twice a day. Remove your barrier protection before you leave your workplace. So your operatory, your lab, your instrument processing areas. Now your forearms, because you are chairside and the amount of aerosol that we were talking about should be covered. And because you're not scrubbing your arms between patients up to your biceps, right? So they're covered in aerosol. They're covered with contamination. The same thing with your hair. And we know hair is contaminated. I used to do in public health clinics, I cut out a lot of amalgams. I did a lot of hygiene, and I'd go home and I'd have amalgam in my hair and calculus in my hair. And when I look back on those days, how crazy that was. Cover your hair. You're going home, you're making dinner, you're picking up your kids at childcare, hugging your wife, your husband. Believe me, I've survived one of these illnesses. You don't want to ever have this or take it home with you. Cover your hair. So chairside, your gloves should cover the elastic wristband so your arms are not exposed to the contamination. We said we're going to wear gloves when we come into contact with contamination, remove gloves after patient care, and wear a new pair of gloves for every patient. Back in the day when dinosaurs roamed the earth, I know there's a few of you out there along with me, I had professors at UCSF washing their gloves because they didn't know what to do. They had never practiced wearing gloves before. So they thought it was going to denigrate the level of or the quality of dentistry that we would be providing as graduates and so forth. So between the patient checks, they'd be washing their gloves until finally someone at UCSF said, hey, no, you're not going to wash your gloves. You're going to change your gloves, wash your hands. And remove any gloves that are torn, cut, or punctured as soon as you can. Wash your hands before regloving. Do not wash surgeons or patient exam gloves before use, or wash, disinfect, or sterilize gloves for use. I gave you the example of an employer that I had right out of my dental assisting program where we sterilized our surgeons' gloves. And we reused them over and over and over again in a chemclave. Ensure that the gloves are appropriate in size for you, that they fit you. Use appropriate gloves for the job. So if you are turning over an operatory, you should be wearing heavy-duty puncture and chemical-resistant utility gloves. When you're handling instruments, the same. Consult with glove manufacturers regarding the chemical compatibility of glove material and dental materials used. So when I was a dental assistant, same employer that had us sterilize the surgeon's gloves, and I got one. He would take all of the dirty instruments and he would put them in the sink in the operatory, and he'd fill that sink up with sudsy, soapy water. And there was an instrument brush there, like just a hand brush. And it was my job to stick my hands in that water without gloves on, fishing around for instruments and scrubbing them, rinsing them, letting them dry, and then processing them in the chemclave. And I got stuck multiple times. In fact, I had a herpetic whitlow from a dirty hygiene skill. Sterile surgeons' gloves and double gloving during oral surgical procedures. The CDC believes the effectiveness of double gloving has not been demonstrated, and they consider it an unresolved issue, even though they state that the majority of studies among healthcare personnel and dental healthcare professionals have demonstrated a lower frequency of inner glove perforation and visible blood on the surgeon's hands when double gloving. But they believe it's, according to the science, they believe that it's not been demonstrated that it's effective. All right, contact dermatitis, latex hypersensitivity. Educate your staff on the signs, symptoms, and diagnosis associated with frequent hand hygiene and glove use. Screen all patients for latex allergy. Make sure that your emergency kits are latex-free. And have emergency treatment kits, again, with latex-free products. I've only had 2 patients during my career that had a true latex allergy, and I was associating with one of my instructors at UCSF who was a hospital dentist. And at the time, he had a patient. So we had to have the office mitigated for latex, and we performed, I think, all the procedures on this patient at one time. All right, so it's a type 1 hypersensitivity to the natural rubber proteins in latex, and reactions can be upper respiratory. In the case of this patient that we were seeing, they had an actual anaphylactic reaction to latex. Sterilization and disinfection. Okay. Thank you, Hannah. I appreciate that. Passcode has not been shared yet. Now I realize that I did not take down the call to action banner. I'm going to put up the one from earlier today. So grab the instructions in the handouts. If you don't have it, that will explain how you'll get CE credit today. I've noticed that a lot of assistants wear Crocs. Do you think Crocs are okay, or do you recommend shoes? I don't think Crocs are problematic. I just think they need to leave them at the office and not wear them in their vehicle or home. And I will tell you why. And I'm going to show you a couple of videos here. When I had C. difficile, in order to be entered into a clinical trial for a fecal transplant, I had to have my home mitigated for C. diff spores, my vehicle mitigated, and our offices at Dental CE Academy in Phoenix mitigated. And I had to call a biohazard team to come in. And then afterwards, I did not wear my shoes in my house because I didn't want to bring in any contamination, right? So that was a requirement to be able to be entered into a clinical trial at Honor Health. And what they used was hypochlorous acid when they came in, and that's how I found out about hypochlorous acid. So if they're wearing Crocs, if they leave them at work, as long as they're going to protect themselves if an instrument falls on their foot or something, yeah. Yes, Lysol has a bleach-free clothing disinfectant, and it's in the course technology sheet that I have in the course folder, Lysol laundry sanitizer. If you tap on the red banner, you'll be taken to the course folder, and you'll see that document. That's crazy. Tara, that is crazy. Passcode not announced yet. I witnessed a dentist wipe her gloves with a cava wipe while doing an extraction if too much blood was on the glove. I personally think we have an issue with quaternary ammonium compounds, and you'll see two documents in the course folder. One that was published summer of 2023, evidence-based peer-reviewed journal on the hazards of quaternary ammonium compounds for the respiratory system, fertility, and so forth. And they're concerned about lack of regulation. We're also polluting the planet with those microfiber cloths. Dr. Christensen, Rella Christensen, there's another document in your handout. They don't use these quats anymore because they don't believe they're effective. And who's going to be able to turn over an operatory with 3 of those wipes sufficiently? Isn't going to happen. Also, those wipes cause more cross-contamination of some of the pathogens that we're worried about, including C. difficile spores. Always in sports mode with Crocs, right? So you'll find the Lysol product goes in the wash and follow the instructions. Sterilization and disinfection. All right, I'm going to show you 2 brief videos here. Okay, this one's called The Dirty Dentist. That's their title, not mine. And I will put this link in the chat area. I'll let them tell the story. This was a dentist in Oklahoma, an oral surgeon who decided to cherry pick the patients and apply a different standard to sterilization. We'll talk about this story momentarily.
Health officials are saying that a Tulsa dentist may have exposed thousands of patients to life-threatening diseases ranging from HIV to hepatitis. ABC's chief health and medical editor, Dr. Richard Besser, is here with this disturbing story this morning.
It is disturbing. You know, I've spent my career in public health, and it's not hard to prevent infections in dental offices. But what they found here was absolutely shocking. Dr. W. Scott Harrington has been a trusted oral surgeon for 36 years. But now authorities believe he may have exposed thousands of patients to potentially deadly infections by allegedly using rusty instruments which weren't cleaned properly. Letters are being sent to 7,000 Oklahoma patients recommending they immediately be tested for hepatitis B, hepatitis C, and HIV after one of his patients with no known risk factors tested positive for hepatitis C. In addition to allegations that he cleaned his instruments by improperly bleaching them, which caused them to become porous over time, he's also accused of reusing needles and vials.
The instruments that came out of the autoclave were horrible. I wouldn't let my nephews play with them out in the dirt. I mean, they were horrible. They had rust on them.
He even reportedly had medications 20 years past their expiration date and allowed unlicensed assistants to give IV medications. We reached out to Dr. Harrington, but he did not return calls.
So 7,000 patients have gotten these letters to get tested for HIV, hepatitis C, hepatitis A. I mean, what are the chances more patients are going to test positive, given those conditions?
Yeah, I mean, there are a couple of disturbing factors here. You know, many patients in his practice have HIV and hepatitis C and hepatitis C.
He was treating a higher risk population.
He was, and he had instruments set aside for those patients and other instruments for patients where he didn't know that whether they were infected or not. That's very dangerous. All instruments should be treated the same. You know, last summer there were 8,000 patients from Colorado who were notified, and thankfully none of them were infected. Here, there's a much higher chance someone could get sick.
But I would have thought soaking instruments in bleach would have killed anything. We keep hearing bleach is the only thing that kills everything.
Well, for a lot of things, bleach is the way to go. But these instruments have to go into something called an autoclave, which uses pressure and heat. Mm-hmm. If you use bleach on them first, it disturbs the outside of the instrument so that the autoclave autoclave no longer works.
And they become porous and things can get
They
inside.
can seep in, and then the heat and the pressure don't kill those germs.
So what are you supposed to look for, Rich? I mean, I go to a dentist office, and usually I've got so much stuff in my mouth I can't see what's going on.
A couple clues to look for. The first thing, if you ever see rusty or old instruments, that's a warning sign. The other is if your dentist isn't wearing gloves or isn't changing gloves between patients, find another
So
dentist.
he should do that in front of me.
Yeah, definitely. You should see that they're putting on fresh gloves.
Okay,
Definitely.
and pay attention to those instruments.
That's
All right,
right.
Rich, thanks so much. Disturbing news will keep.
Okay, so for a couple of you that could not hear the video, again, the link is in the chat area. Any comments? Let me ask what you would do if you were working in that practice and you saw this going on and you knew this was going on and you knew that it was not correct. It was not what you were trained and it wasn't ethical treatment. What would you do in that case? These are good answers, everyone. I'm really impressed. So many of you reach out to me after this with these similar stories and not knowing what to do. So I'm going to go through a few of these, and some of them, there's some overlap here. So if you don't see me posting yours, don't get your feelings hurt. It's just we have some duplicates here. All right, so I want to tell you first. There's one here about they would probably run out of there and go get a different job, right? Many of you say you'd report. One here, I would probably talk to the dentist first, and if nothing changes, I'd report and then go to work at a different office. That's a good approach. So always take your concerns to management in a written fashion, whether it is by email, so it's something you can memorialize the conversation, or a written letter that you hand deliver. Because I can tell you, in the case of this one situation that we just saw from the news, Dr. Harrison in Oklahoma, or Dr. Harris, many of those cases, and I've actually had to accompany investigations, what they're doing, these are oftentimes practices that are under investigation for something else as well. Your patients are not going to know if you are soaking your instruments in bleach. That came from an employee, right? It had to come from somebody that was associated with the practice, or somebody that was undercover working in there, that was undercover because they were investigating something else, or both. And in the case of Dr. Harris, he actually was found guilty of Medicaid fraud. And he was, I believe, under house arrest as well. So Medicaid fraud investigations can take years. And if you're in a practice that you're being told to do something in terms of infection control that you know is not correct, bring your concerns up, as we've heard somebody say here, to administration, to the owner dentist, whoever it is, in writing, and ask them to make the correction. And if they refuse to do it, then chances are you're going to be on your way. You're not going to subject yourself to that kind of liability, and report it. Report it to the board. Because if they were under investigation too, or there was another infraction that they found, they're going to look, they, meaning the FBI, the Office of the Inspector General, and so forth, are going to look to see, and the state, who was working in that practice during that time. So even if you cut and run and go to another practice and do nothing and you think, okay, shoo, I'm out of there, you may not be, because they will find you and they will ask you if you were working in there at that time and what did you see and why did you not report it. There are no states except for 2 that have an entity that comes in and routinely inspects dental practices. It's not like hospitals and JCO. Nobody comes in to your dental practice and makes sure that you are doing what you're supposed to be doing. You are on your honor. And when you relicense and when you became licensed, you signed an affidavit stating that you understood you had to uphold your state Dental Practice Act. And if you are being told to do something and you comply, you're not upholding your state Dental Practice Act anymore. And in the case of Dr. Harris, quite a few of those employees also had allegations filed and charges filed against them. So you can't say, well, my doctor told me to do that, so I'm a lemming and I'm just going to do what they told me to do. You can't do that because you're the one that's licensed or certified. And even if you're not licensed, you're still going to be found liable potentially. And I'm not an attorney, but I've seen these cases and I've had to go into practices with the FBI there, investigating these folks. They're trying to get a foot in the door. They'll go undercover, etc. So it's important to understand that you can't just drop and leave and think, okay, well, I'm not responsible for any of this, because you still are. If you know in some states that you are using instruments that are potentially not sterile on a patient, that is assault and battery. You could be arrested. Assault and battery, because you could kill someone using instruments that are not sterile. So it's very serious. And I want you all to understand that. Make sure you know who to report to in your state, and usually it's your dental board. OSHA does not disclose who told, and neither would the dental board unless there was some reason that you had to testify in court. So yes, start with your administration. And you know, I was in a practice once where they were all wearing disposable gowns and they were being told to wipe their gowns off with Cava wipes and use them for 3 days. And they were all doing it. And the person telling them to do it had no background in healthcare. She had a degree from Arizona State in hotel management. And you had licensed personnel listening to this woman, wearing their gowns for 3 days and wiping them off with Cava wipes. I'm like, what is going on here? You know, you all are the eyes and ears of the profession, and the states depend upon you because you're in there to do the right thing. And the right thing is to bring it to the attention of the practice. And if they fail or they refuse to make the correction, then you have to report it. And for your sake, you might be looking for another job. I don't have the states offhand. Yes, I'm very familiar with OSHA. So OSHA can come into your office to check protocol. OSHA is there to protect the employee, not the patient. So the dental board is there to protect the patient and the employees. I worked with a dentist who says if we ever reported her to OSHA, she'd know because she knew someone there and said she would come after us. Well, then she might find herself in a bunch of legal trouble because retaliation is not tolerated by OSHA. Janelle, you can reach out to me later on that. All right, let's get through the rest of this. So I just wanted you to know that you have a recourse for these things. Don't just do what you're supposed to do. All right, instruments, critical, semi-critical, non-critical items. This is Spalding's classification: critical, semi-critical, non-critical. Critical items have a high risk for infection because they penetrate normally sterile tissues. Semi-critical would contact the oral mucosa, non-intact skin, but not penetrate soft tissue or bone. And non-critical items. These would be instruments, devices, equipment, surfaces come into contact with soil, debris, saliva, blood, OPIM, and intact skin, but not the oral mucosa, so everything else. So when we look at critical instruments here, we autoclave these, or we use sterile single-use disposable devices. These could be surgical instruments, scalpel blades, periodontal scalers, surgical dental burrs. Now, semi-critical instruments, the CDC believes a dental handpiece is a semi-critical instrument. How many of you here today, again, this is anonymous, how many of you are told that you don't have enough handpieces, so you're going to use Cava wipes on your handpieces instead of autoclaving them because you don't have enough? Go ahead and type yes or no in the chat area. Again, no judgment. There may be a right or wrong answer, but no judgment. This is for my own. We had someone here that posted they had someone that, an employer, I believe, soaking their instruments in bleach. Oh, here we go. I saw assistants soak instruments in bleach after extraction and then autoclave. So that is not correct. No, you do not soak your instruments in bleach ever. Ever, ever, ever. Okay, so let's take a look at these answers here. Obviously, we can't rely on individual ethics or oaths. Why is there not a supervising agency for dental practices? Well, when you signed up for dentistry, you are to rely on individual ethics and oaths, but it's difficult, right, for others out there if they don't have the same ethics as you. There is not a supervising agency for dental practices outside of dental boards, and they're a bit busy. So there is no regulatory agency that will come in. Unless your practice is an FQHC or you're associated with an FQHC or a hospital, in most states, there is nobody that will come in and inspect practices to make sure that you're doing what you're supposed to be doing. So we have a few of you that are told you don't have enough hand pieces, and that includes, by the way, your prophy motors. So we do need to autoclave. We do need to autoclave our hand pieces and check with your instructions for use, because the internal components of that hand piece have to be cleaned because of biofilm. Hand pieces, when we use them, there's a vortex, especially with our high-speed hand pieces, that can be created. I mean, you've seen your prophy hand pieces, right? You're using the disposable, and you've got saliva and prophy paste wrapped around the top of that disposable handpiece. Well, what happens is that with your electric handpieces, not as much, but follow the instructions for use. There's a vortex that can be created. So it sucks back in saliva, blood, debris, etc., into that handpiece internally. And if you are not autoclaving it and you're not cleaning the internal components of that handpiece, not only can you be transmitting infection to your patients, but you can also be creating more pathogenic air quality, because all of that stuff is getting blown out of the handpiece into your operatory, especially being connected to the air water lines. So the handpieces have to be autoclaved, even the prophy motors. Now, some of your cordless follow your instructions for use. Some of the electric handpieces have a retraction device in the head of the handpiece, but by and large, all of your handpieces have to be autoclaved. What do you do when you're told to use a handpiece that's been wrapped in a cava wipe? If you use it, that's a big problem because you could potentially kill someone. You could be infecting them with something and they could die. All right, so dental mouth mirrors, amalgam condensers, autoclave. Anytime you can autoclave something, it's best than relying on cold chemical. Non-critical instruments and devices, x-ray heads, face bows, pulse examiner stuff. We're going to show you something that you can use with hypochlorous acid for all of these surfaces, including your non-critical instruments and devices. So OPIM just means other potentially infectious materials beyond blood. Sterilization and disinfection of patient care items. I'm going to show you another quick video here. So this video is from Contagion Live, and they are talking about the community spread of Clostridium difficile. So that means transmission outside of a hospital stay, and they call out dental practices. So I want you to hear this, and I'm going to pull up the video. In the meantime, if you have any questions, let me know. If I somehow missed your question, please repost it for me. If you've taken my C. diff class, my apologies in advance, it's the same video. So these are 6 experts. They're infectious disease experts, they're gastroenterologists, and they have expertise in the area of C. difficile. Dr. Paul Furestad is a globally recognized expert in Clostridium difficile infections. And they're going to talk about how Clostridium difficile is transmitted in the healthcare setting and why it's important to understand that these pathogens can follow you home, not just C. diff, but others, and why infection control is essential, and the way we prescribe antibiotics.
So let's talk about community C. diff, if we could, for a moment. What are the risk factors in the community, and how do they differ in the community versus the hospital-based population here? Dale, you want to start us on that?
Yeah, that's a really good question, because there's 2 factors that we need to have in order to get C. diff. One is antibiotic use, and the other is exposure to the spores. So the spores are ubiquitous. They're out in the environment. They even contaminate at a very low level some foods, meats, root vegetables, lettuce, and those are probably how patients in the community get exposed. They, on the other hand, when the CDC has looked at community-associated C. diff, they found that about 80% of these patients have had an exposure to healthcare as an outpatient. So it's doctor's office, dental office, and chronic dialysis units, ambulatory surgery. And this is where you have 2 risks. One is that somebody's going to give you an antibiotic, and those are called doctors. And
we hope it's only doctors.
They put people at risk of C. diff. And the other exposure is that the healthcare environment is more contaminated with C. diff spores than is the environment outside of healthcare.
And I think it's worth noting, Paul is nodding his head. He does a lot of nodding. It's not just the people who are in the healthcare system. It's not just the people who got the antibiotics. They go home. They've got spores, and then their families are exposed. So it seems to me that that's part of the issue, isn't it?
And those spores can live for a significant period of time on many different surfaces, even when exposed to sunlight. And you'll see some data that says alcohol in certain products can kill the spores, but that it really has to be used properly, where the liquid sits on a surface for a significant period of time to have its effects. So the fact that the spores can be taken home with you on your lab coat and in your house and on surfaces for 6 months or a year or longer certainly put people at risk.
Okay, so question, what about the Freedom cordless motor? Again, refer to your instructions for use. If you're using a device that you've never read the instructions for use, I mean, I bet there's a lot of you that probably read more instructions for use for your air fryers than you have for most of the equipment in your dental practice, right? We don't think about it. We get trained to do something. We get in sort of a rut. If you haven't read your instructions for use for your equipment that you're using, and you don't know how to take care of your cordless motor or cordless, Freedom cordless, time to take a look. That's your homework for the day. Because you might be surprised. There's only one quiz, so you're fine. How long can C. diff spores live on a surface? Months to years, sometimes indefinitely. All right, so questions here. What do I recommend for disinfecting intraoral cameras? So oftentimes they have plastic covers for the camera that you should be using. Find out from your manufacturer and find out what they recommend for disinfecting. And I'm going to show you some things. How about XCP? I work as a temp and they only spray with cavicide. Wrong answer. So XCPs can be autoclaved and cavicide should not be used on them. Yeah, I'm glad you brought that up. Thank you, Jessica. Good question. And again, look up the instructions for use for your XCP. Right? It should probably go in the ultrasonic cleaner and then bagged up and put in an autoclave. So Freedom cordless Profi motor, again, check with your instructions for use. Cavitron, the same. So many of you may be told to just wipe off the housing for that. Take a look at your instructions for use. You might be surprised. For hygiene polishers, is it sufficient to wipe throughout the day and sterilize at the end of the day? No, it should be autoclaved between every patient. And let me turn that around. Would you want someone polishing your teeth with a device that only gets autoclaved once a day and wiped off with CaviWipes? How many of you would want that device used on you? If there's a yes, if there's a wise guy in the audience, go ahead. I would say probably none of you would want that handpiece used on you, right? There's no way. There's no way. And thank you. That was a very good question, Shanika, and I'm not singling you out at all. I'm saying let's think about this. If you're in a practice which you wouldn't have anybody perform a procedure on you or bring your family into, we've got a problem, right? Okay, let's be realistic then. What are we supposed to do when owners won't order at least 8 polishers for us to use throughout the day? You find another job. That's what you do. Or obviously it's not the right place to be working. And if they're going to put you to that liability, they're saying to you basically, I don't care about your job. I don't care about the patients. We don't care if we're not using sterile instruments. And that probably isn't a place that you want to work. And if you've brought it to their attention, then it might be time for a report to the dental board because they're not sterilizing their instruments. Pretty simple. All right, we use only FDA-cleared medical devices for sterilization. So if you're buying your autoclave off of Alibaba or eBay or something, it needs to be FDA-cleared. Clean and heat, we spoke about critical, semi-critical, and Non-critical items. If your bags become torn, they need to be reprocessed, starting with the ultrasonic cleaner, and then they need to be autoclaved. Your sterilant should be FDA cleared. And we're going to see you need to pay attention to the EPA list as well. Single-use disposable instruments are acceptable if you're going to use them once and dispose of them correctly. We don't use liquid chemical sterilants or high-level disinfectants for environmental surfaces for disinfection or as holding solutions. Cavicide, we should not be wiping down hand pieces with cavicide or ultrasonic cleaners, ultrasonic scalers, excuse me. Non-critical patient care items should be barrier protected or cleaned. I'm going to show you a demonstration video here in a minute. If they're contaminated with blood, use an EPA registered hospital disinfectant with a tuberculocidal claim. We are making the recommendation that you use an EPA registered hospital disinfectant off of List K. List K. That includes C. difficile spores and everything else you need to be concerned about. And then your staff should be informed of all OSHA guidelines for exposure to chemical agents for disinfection and sterilization. So this is off of Yelp. Somebody took a photo of a burr block, a patient. They took 38 photos, by the way. My question is, who would leave a patient in an operatory with the tray uncovered long enough to take 38 photos? Where was everybody? But they took 38 photos. And somebody posted here, this was April 2022, the tool bits for my root canal does not seem up to date or sanitary. Tetanus, anyone? Tetanus is a problem, yeah, but that's the least of their worries here. And dirty burr block, rusty burr block, but let's look at the next photo here. This was the patient's tray. What's wrong with this picture here, right? We have cords, dirty, filthy cords dragging on the floor. And, you know, sometimes they do have to be on the floor because we have enough length so that we have enough length to be able to reach the patient during the procedure. I get that, but you can't disinfect these cords, not through that much dirt. This requires elbow grease. In this case, swap them out, get brand new ones and use cord covers, barrier protectors. They've barrier protected the air water syringe. They've barrier protected the unit control. They've got a tray cover on the tray, but look at the rest of this. Dirty triangles laying on top of a composite syringe that's not protected, syringe needles exposed, and so forth. It's kind of a mess. Root canal. These are what patients post on YouTube now, and I'm sorry, on Yelp. So hand pieces should be autoclaved, and check your instructions for use. Is it not considered gross to not autoclave everything that goes into a patient's mouth before putting it into another human's mouth? No judgment, serious inquiry. Dental loops. So dental loops, follow your instructions for use. There are now face shields that you can use with loops that give you enough room and they're not hitting your chin, so you can protect those as well. And there are handles on your loops that can be autoclaved. So you can change those handles out between patients if you need to, or you can flip it up with your elbow. Do you use barrier tape on light handles and other surfaces in operatory? I'm going to show you what we use and what we recommend. What if you use barriers on your XCP? Autoclave them. Those barriers aren't foolproof. Yep. Those spores can live for a long time, and your patients can shed spores for a lifetime. The office I work at just wipes off curing lights, no covers. I voiced my concerns, but they don't seem to listen. I always had the mindset, if I wouldn't want this for me or my family, I'm not doing my job, right? What do you think about disinfecting and sterilizing in cold storage? I don't like cold sterile. If it's if you have an autoclave and it's autoclavable, that's preferable. We did not get to water lines yet. Okay, gonna move here at high speed. All right, your instrument processing area should be divided spatially between receiving, cleaning, decontamination, preparation, packaging, sterilization, and storage. We minimize handling of loose contaminated instruments. We use automated cleaning equipment first, make sure that all the debris is removed from your instruments, and use work practice controls that minimize contact with sharp instruments, wear puncture and chemical resistant heavy-duty utility gloves, and wear appropriate PPE. And most of the time, those heavy-duty gloves now are autoclavable. Preparation and packaging. Some states do require you to label either date-related or event-related. Chemical indicator in each package or on the outside if you can't see inside, and use a sterilization process that has received FDA clearance. Unwrapped instruments, you can sterilize unwrapped instruments if you're going to handle them aseptically and use them right away, but we don't sterilize implantable devices unwrapped, and we don't store critical instruments unwrapped. Storage area for such, we spoke about date-related or event-related. Label your instruments with which autoclave they came out of. Sterilization monitoring should be performed at least weekly or more if you are processing quite a few instruments. I happen to like in-office testing, spore testing again. And notice I say spore testing because they're using a form of Clostridia usually to spore test these autoclaves because the spore is so hardy. It's not the pathogenic form. So you're testing to make sure you have enough heat and pressure to kill the spore, and that's how it is tested. It's a good idea to send those autoclaves out for frequent I guess it would be a tune-up, basically. So every day your autoclave requires maintenance, weekly maintenance, monthly maintenance, and then about annually you can have your rep bring you a loaner or loaners and send these out to be cleaned up. They'll check the gaskets. They will check and make sure it's the correct temperature, the correct pressure. It's going to save your investment. I've opened up doors and I've seen this mold growing in the vinyl and so forth. Now I'm going to look a little deeper in the rest of your practice because it tells me you're taking one of the most important devices you have in your practice and you're not caring for it. So what else is going on that I need to look at, right? Recommendations for positive spore tests, repeat it. If it still comes back, then you're going to have to send the device in. And when it comes back, you'll test it with 3 empty chambers and document that. All right, environmental infection control. I'm going to tell you right off the bat that we recommend hypochlorous acid rather than the cavicides, but it's up to you what you use. We just look at the science here. If you're trying to control the spread of many of these infectious diseases, hypochlorous acid, first of all, is non-toxic. Your body produces it. We recommend using a system. You drop 4 NADCC tablets in a liter of tap water that attaches to a sprayer. You wipe down with dry wipe first the areas that are most heavily contaminated, right? What we call high use areas. So the chair, the countertop. Then you come through and you spray it down with the sprayer and the hypochlorous spray. So I'm going to show that to you now. 2 quick videos here. Not wearing the mask. Veterinarians use it. You can use it for pets. It's used in wound management. And you can use this on every surface. It can also be used, there's a form of this that has a surfactant in it, so it's used for your flooring. You can spray down your furniture. You can spray down your blood pressure monitor, the curtains, the patient's chair. And used in a dental operatory, it takes 4 minutes. So this device, the sprayer, is chargeable, and you'll get about 10 operatories or so to 1 liter of solution. So you can make it as you go along. It dissolves very quickly. All right, that is hypochlorous acid. I'll show you one more being used in a dental practice. She's using a little different device. Okay, so again, a little bit different device. You don't need all of that stuff on your countertops either, the little glass jars and so forth. Get rid of anything you don't need on your countertops. All right, so your clinical contact areas, housekeeping surfaces would be your countertops, flooring. Clinical surfaces would be anything that our hands come into contact with or the patient. Again, we recommend EPA List K. You don't use you do not use liquid chemical sterilants or high-level disinfectants for disinfection of environmental surfaces, and use PPE as appropriate. So clinical contact surfaces, we can barrier protect, and again, we recommend EPA List K. And the manufacturer is EvaClean or EarthSafe. If you go to their website, you will see the hypochlorous acid. It's also available on Amazon. So here's another Yelp review here, and this is a chair that's duct taped. I've worked in public practice, public health practice, and I laugh, but I've been in clinics that looked like this, all right? And I shake my head. But they're well-intentioned. They've got a headrest cover here. All right, housekeeping surfaces again, EPA List K, hypochlorous acid. If you have someone coming into your practice that is performing housekeeping for you, take a moment to find out what they're using. If they're using the same mop head as gastroenterology down the hall, you may want to make sure that they're using disposable mop heads and hypochlorous acid. Spills of blood and body substances, hypochlorous acid, carpet and cloth furnishings, hypochlorous acid. You can spray the furniture, you can spray the carpeting. We asked earlier about, does your disinfectant kill C. difficile spores? Why is it important? We saw the link there, and we just watched the demonstration on hypochlorous acid. So this is one of the electrostatic guns that are out there. What it does is it electrostatically charges the solution as it goes through the nozzle, and it creates a wraparound effect. So not only are you spraying the front of the device, it will wrap around and reach the back where you can't. And these are some courses that I offer on the topics on our website. Okay, regulated medical waste. Follow your local municipality and find out if you need to be using barrier protected bags, red bags, etc. Dental unit water lines. So this is a course that I present live every month. Dental unit water lines. So whether you're using a reservoir bottled system or tap water, you have to treat the water and you have to test the water. And your water should be less than 500 colony forming units per mil of heterotrophic water, which is drinking water standards according to the EPA. All right. And the only way you're going to know if your water is safe is by testing it. There is an in-office test. It's in your technology sheet called Exact Blue AquaVial Quick Check. They will test for 12 pathogens. You can check it right there in your office. You don't have to send it in to a lab. And their results are as accurate as any lab out there. All right. In terms of your anti-retraction mechanisms for your water lines as well as your vacuum lines, which are different, check with your manufacturer. So depending on what your system is, what your unit is, instructions for use. Is it going to be the straw method, etc.? Check with your manufacturer. And then test your water lines. We go into much more detail during the course that I present, which is available to you today on demand as well. Outbreaks of non-tuberculous mycobacteria infections highlight the importance of maintaining and monitoring dental water lines. This was a system that went, or a situation that went bad, went south pretty quickly. This was a dental practice, a pediatric practice in Southern California where they were not treating their water lines. They were not testing their water lines. And several hundred children were exposed to non-tuberculous mycobacteria during pulpotomy procedures. And about 70 of those children were hospitalized. They lost permanent teeth. They lost jawbone. Some of them were hospitalized a year and a half after they were exposed. Some of them had to wear a PICC line and have antibiotics for months and months and months. So again, the message here is that we have to treat our water lines and test our water lines and shock our water lines. A boil water advisory, if you're ever in one of those, follow your local municipality, but you cannot use your water to wash your hands or in your unit. We talk about that in the water safety course. When your boil water advisory is over, you're going to want to test your water lines, and you may want to even consider changing your water lines. Special considerations here. Dental handpieces and other devices that are attached to air water lines should be autoclaved. Back in the day when I was an assistant, we just wiped off the handpiece with a 2x2 gauze and alcohol and ran lubricant through it. Right. So anything attached, including your cavitrons, there is autoclave process, there's sterilization that is required. Follow your instructions for use. Dental radiology, hypochlorous acid, if you're using your sensors, etc., double check with your rep, with your manufacturer. Use FDA cleared barriers. Aseptic technique for parental medications, I'll have you review that on your own. Single use. Disposable, use them once, dispose of them appropriately. Pre-procedural rinses. At the beginning of the pandemic, the ADA recommended chlorhexidine gluconate, povidone iodine, or hydrogen peroxide. What do we know about hydrogen peroxide? It's totally ineffective. In fact, Health Canada banned the use of hydrogen peroxide because it doesn't work for COVID-19, for SARS-CoV-2, excuse me. Chlorhexidine gluconate is a very poor antiviral. You'd have to rinse with it for almost 60 minutes to have some efficacy against SARS-CoV-2. Povidone iodine is effective, but povidone iodine is an umbrella term for a solution of multiple iodines, about 5 in total. If you want to be sure that you are using a pre-procedural mouth rinse that's going to work, molecular iodine. Molecular iodine is second in efficacy to rinsing with sodium hypochlorite. And if you want to know more about molecular iodine, we have several courses on our website. You'll see a link in your folder. But molecular iodine can be used on it as a daily maintenance for gingivitis, periodontal disease, or prevention. It can be used as a pre-procedural rinse. It can be used in your ultrasonic scalers for quadrant scaling and root planing. It can be used post-operatively, but it's a pre-procedural rinse, molecular iodine. It does not stain, it is not allergenic, it does not interfere with thyroid issues. So go to our website, you can learn more. Oral surgical procedures, We perform surgical hand antisepsis. We use sterile surgeon's gloves. We use sterile saline or sterile water as a coolant or irrigant in sterile devices or sterile disposable devices. Handling of biopsy specimens, they should be placed in a leak-proof container with the biohazard symbol. Handling of extracted teeth should be autoclaved unless they contain amalgams. Dental laboratory, I can't think of a better place to use hypochlorous acid. You can use it on your impressions, but again, check with your manufacturer, surfaces in your lab, etc. Anything like metal impression trays, Facebook forks, if you can autoclave them, autoclave them. Laser electrosurgery plumes and surgical smoke. If you are using any of these, and I know there are a few of you that are using laser, you need to be using a dedicated device for the laser plume. And there are studies that show that gynecologists that removed her HPV lesions developed the same HPV lesion in the oral pharyngeal area when they were using LEEP or laser because they were inhaling the plume. Mycobacterium tuberculosis, again, find out how often in your area it's recommended that you are tested. And Creutzfeldt-Jakob disease and other prion diseases, the CDC believes it's an unresolved issue, but they believe that the transmission in dental and oral surgical procedures is low to nil. Finally, program evaluation is important because program evaluation, you don't know if your program's working or not unless you evaluate it. So take a look at your sharps injuries, find out, did you change needles perhaps? Some people are getting stuck more often because the caps are too sticky. I've seen that. So again, look at your evaluation of your program. That is the link to List K, EPA's. And again, if you leave here and go to Amazon and you buy Smart Hypochlorous Acid, that is not going to kill spores. If you're making your own tabletop, that is not going to kill spores. It's not enough of a concentration. Here are other free resources on our website. Here is the oral rinses course on molecular iodine, course on C. diff is Monday, and others, and they're all here for you. November is C. diff Awareness Month. That is me in the lower left-hand corner. We support it every month here at C. diff. We support C. diff awareness every month here at Dental CE Academy, and this is the link to the antibiotics course. I'm going to play a quick video from Dr. Palmier, and then we'll put the code up on the board. I am a public health dentist, and I developed a life-threatening Clostridium difficile infection about 2 years ago that followed a dental procedure and antibiotics that were prescribed just in case I developed an infection afterwards. And I later found out that I didn't need those antibiotics, and that infection almost killed me. So I'm now collaborating with Dr. Palmier to present courses that are relevant to all of you so that we can practice safely, so we know how to prescribe antibiotics for prophylaxis, for odontogenic therapeutic uses, reduce the risk to our patients, reduce the liability to our practices. Really excited and honored to introduce to you Dr. Palmier.
Thanks, Dr. Kroling. And just a little bit about myself. I'm a 1987 graduate of Ohio State University College of Dentistry, and I had microbiology as my undergraduate degree. I've always had an interest in microbiology and antibiotic use. I was fortunate enough to serve on the expert panels of the American Dental Association and the American Academy of Orthopedic Surgeons, and co-authored the guidelines on appropriate antibiotic use for patients with prosthetic joints, as well as the ADA's clinical practice guideline on appropriate antibiotic use for endodontic infections. I've done cardiac clearances for hospital surgical programs for 20 years, so I've always picked up on the literature. And unfortunately, Dr. Kroling's story is not unique. We know in the United States, nearly 30,000 people die every year from C. diff antibiotic-associated infections, as well as another 35,000 patients who die every year from antibiotic-resistant superbug infections. That equates to nearly 175 people dying every day in the United States from an antibiotic-associated infection. dentists prescribe nearly 10% of all prescriptions. So that means we're contributing to thousands of deaths per year. And we know that over 80% of prescriptions that dentists write are not concordant with the guidelines, and most are written for prevention. So in an effort to prevent an infection, we actually may be harming our patients. So many of you may have said, I've taken courses in the past, many of them probably by pharmacists or pharmacologists. And while they may know the material, they can't understand it or help you use it in a daily basis in your clinical practice. I'm a practicing dentist every single day. I'm also in the hospital today. I teach our residency program. And not only did I help write the guidelines, but I can help you understand how to use them appropriately in situations in your daily practice, such as you have a patient who has had a joint replaced and their orthopedic surgeon wants them to use the antibiotic prophylaxis. The patient prefers to use it. They show up and they haven't taken it. What do you do for that patient? We can show you how to handle that. How do you talk to the patient?
Okay, we're going to put the code up on the screen. So that is information about Dr. Palmier's course coming up, and it's available also from as a recording too. So the code is 892953. 892953. We recommend that you write it down. Please wait 30 minutes before you request assistance, because it could take that long today, although it looks like it's going to be quicker. 892953 is your code. I'm looking at the questions right now. Lisa, are you talking about the link to the hypochlorous acid? If so, let us know. No, this is not a 3-hour class that was in the agenda. He wasn't using a mask in the video. Is it harmful to breathe in? No. Many of you were using hypochlorous acid in foggers at the beginning of the pandemic. If you walk into a grocery store and you hear the misters coming on, that is hypochlorous acid. It's a food grade concentration though, okay? It's used for water decontamination as well. There are no health concerns. Your body produces hypochlorous acid. So it does not leave the surfaces super wet. It creates a mist, a very fine mist. It takes about 4 minutes to turn over an operatory. It should come into contact with the surface for 4 minutes. So you are much safer using hypochlorous all day, every day than you are with Cava wipes. And if you look at the data in the documents that we've included here in your course folder, you'll probably agree with me. You have the link to the hypochlorous acid in your course folder. So if you do not have the course folder, tap on that red banner at the top of the screen. Okay, you get multiple attempts for the quiz. I feel C. diff carries with it a form of PTSD. It sure does. Yeah, I think when you talk to any person that's had C. diff, especially when you've had multiple recurrent infections, it definitely is a form of PTSD. It's called medical trauma. And yeah, so it is problematic. You have up to 7 days to complete the quiz, but we recommend if you can get it in today, that's best. Does not have to be done right away. Thank you, everyone, for attending. If you're a CDA and you don't know your license number, you need to find it out before you complete the quiz because it will need to be on your certificate. So you should be able to look that up online. If you're a student, then put student as license. Hypochlorous acid, yeah, for your rentals. We use it at home. Retake the quiz, use the same link that you received, but you should see a box that will show you how to edit and resubmit. So I use hypochlorous acid now in our homes, in the vehicle. I spray it on the dog beds. I have a veterinary form that I use for one dog that I have that has allergies and she scratches, and it's amazing in terms of its healing capacity, right? So it's very effective. You still wipe off your high-touch surfaces, but you don't use Cava wipes to do that. You'll use hypochlorous acid in a dry towel. Yeah, so they make the hypochlorous acid in two forms, one for the sprayer and one that you can put in a spray bottle. That one in the spray bottle, there are two types. There's one that has a surfactant in it. So it's called a cleaner disinfectant, just like the wipes you use for Cava wipes. And you use it with, they give you dry towels and you spray it and wipe it off. The breakdown with hypochlorous acid is much faster and much more effective than Cava wipes. Much more effective. In fact, watching Cava wipes and watching assistants use Cava wipes, I'm going to say, and I'm being conservative, that 50% of you are rushed. You're not using them effectively and you're not reaching all the surfaces that you need to. And you've been told to use 3 wipes per operatory, right? Many of you have been. Can't assume for everybody. You're not going to be able to disinfect an operatory adequately like that. And even if you were, you're not going to be able to kill everything that you need to kill. The passcode works. Yep. Okay, you got it. Good. %, minimum passing. Be sure you check your spam folders most of the time and be sure that you have entered your correct email address, especially those of you on your phone, because most of the inquiries we get, I can't find, I didn't receive my certificate. Somebody either put in the wrong email, so they never got it, or it went to spam and they said, well, I always get your emails. Doesn't matter. These are attachments. So there's a higher level of security and they may end up in spam anyway. So just save yourself time and check your spam folder. Thank you, everybody. I appreciate you all being here. Great questions today. You were probably one of the best classes I've had, I think, really. You've done amazing work in terms of answering questions and so forth.